Dr. S. Shanthanam is a consultant neurosurgeon at Kumaran Medical Center in Coimbatore. He has done his UG from the Salem Government Mohan Kumaramangalam Medical College and PG from PGIMR Chandigarh, and experienced registrar under Dr. JKBC Parthivan, KMCH Coimbatore, and worked as assistant professor in Department of Neurosurgery in PSG Hospitals Coimbatore, and assistant professor and head of the department Karpagam Hospital Coimbatore, Karpagam Medical College Institution Coimbatore. And his special areas of interest are head injury, spine injury, and brain and spinal cord tumors, the cerebrovascular surgery, congenital and developmental disorders of brain and spine. I welcome Dr. Shanthanam to give his lecture. Shanthanam, please unmute yourself.
Yes, sir. Yes, sir. I mean, sir. I mean,
share.
Yes, sir. I'm sharing the screen, sir.
Yes.
Yes, sir. Sir, good evening, all sirs, and I'm very happy and privileged to have this opportunity to talk in this forum with all seniors, and I'm very much thankful to Rajesh sir, because he has always been a strong motivating factor for promoting such academic activity, and he stimulates all our younger people to come forward for making such presentations, sir. And I really thank sir for also giving me this topic on neuropathy, because of which I had an opportunity to learn more about neuropathy. As we all know, neuropathy is mostly of a neurologist topic, but still nowadays it is a routine practice. We do see everywhere that neurologists or neurosurgeons are there in lot many hospitals without a neurologist in house, and neurosurgeons are in a situation where they need to manage also stroke and seizures and neuropathies. And many times, for want of getting appropriate surgical cases, where we do see that many surgical cases are being managed under neurology and being stretched for prolonged duration before they come for neurosurgery, where we realize that probably if the patient has been referred at an earlier stage, the outcome would have been better. So nowadays we see a lot of neurosurgeons doing routine OP practice in a lot many cities, at least to collect appropriate neurosurgical cases at an early stage, rather than relying for a referral. We ourselves sit in a lot many small cities, and we see routine all cases, and we try to pick up. And when doing so, we encounter many difficulties and problems in symptom management of these patients. So after this topic being given to me, I had a good opportunity to learn more about neuropathy, and I will start on the presentation, sir. So neuropathy for neurosurgeons. When neuropathy said, it invariably means peripheral neuropathy. So peripheral neuropathy means starting from either brain or spine, involving the cranial and spinal nerves. And management is mostly by titration of the available basket of medications, as we have seen from our seniors, learned from our seniors. We have a collection of medications, and we try to titrate these medications and doses, and we try to manage these patients. Then we are having a very good volume of OP patients in small cities. And physiotherapy also has got its own role. And alternate medicine, this also is quite frequently encountered. We see patients going for alternate medicine, and some even come with a smiley face saying that they had good recovery of on undergoing these alternate medicines. There are some licensed and there are some non-licensed, and they are widely available in market. Even some medications, phytotherapies are also coming into picture, where a lot of research is going on, where they consider including those plant-derived chemicals for pharmacological management of neuropathy. But understanding about neuropathy, at least among neurosurgeons, are less, because we don't see and learn. At least during our PG days, we have very less opportunity to see those cases. And most of the time, we enter into the clinical practice, because of our compulsion. We do see a lot of cases, and gradually we learn by error. Coming to peripheral neuropathy, it has got a prevalence of around 2.5%, and prevalence is increasing with age, and around 10% among aged population, and 50% of the diabetics will develop neuropathy in long run in their entire lifespan. And still, leprosy is an important cause of neuropathy in our Southeast Asian population. And most common cause of mononeuropathy is called carpal tunnel syndrome, and most common genetic sensory-motor polyneuropathy is Charcot-Marie-Tooth disease, CMT disease. But in India, it seems the incidence is quite less. Various reports saying between 5 to 10%. Importance of knowing about neuropathy is that it has got a varied etiology. If we go into the textbook of neuropathy, we find pages and pages of etiology and mechanisms, which are really confusing, and manifestations are actually really misleading, where there is a combination of different nerves and different pathologies and different symptoms. And if not treated, they also will have their own complications in the form of, because of neuropathy, patient can have frequent fall with head injury, spine injury, long bone injuries, and they also present with non-healing recurrent extremity ulcers, and they ultimately end up in amputation. So a peripheral nerve is a nerve which includes cranial and spinal nerves arising from the brain or the spinal cord, and it composed of sensory, motor, and autonomic elements. And three classes of nerve fibers are identified. One is large myelinated nerve fibers containing motor and posterior column fibers, small myelinated nerve fibers, and small unmyelinated nerve fibers. Both contribute for pain and temperature sensations, and also for autonomic functions. So this is a categorization. Probably we can see on the left side the motor, which are mostly myelinated A alpha fibers, and they are large and they control muscle control. Sensory fibers can be myelinated, thinly myelinated, or unmyelinated. That is A alpha beta, A delta, or C fibers, and they are usually small and they control pain, temperature sensation, and also fine touch sensations. And the other is autonomic. Again, they can be thinly myelinated or unmyelinated C fibers, and they regulate heart rate, blood pressure, sweating, GA functions, genitourinary functions, etc. Peripheral neuropathies are disorders of peripheral nerve cells and fibers, and there are lot many classifications for peripheral neuropathy based on, say, example, based on distribution. It can be mononeuropathy, multifocal neuropathy, or polyneuropathy, and based on the neural component, it can be neuronopathy or ganglionopathy when cell body of the neuron is involved, and it can be axonopathy when axon is involved, or myelinopathy involving only myelin sheath, or it can also be mixed. These are all the factors which makes the scenario more confusing, because it can have single or multiple mixed combinations. The pathophysiologically, there are three important patterns of nerve injuries. Like we can see on the left side, the first is normal nerve, where we have the cell body, nucleus, axon, myelin sheath, internode, and node of Ranvier nucleus. This is what we have read in our early years. And the three types of degeneration, that is segmental demyelination, the third one, where the segment of myelin sheath alone is injured or pathologically damaged, whereas the axon is intact. And extreme right is the axonal degeneration, where the axons are getting injured or destroyed. And the second diagram showing Valerian degeneration is one of fancy name we would have heard during our early years, where there is involvement of the axons, but there will be a distal to proximal to distal change in the neurons, whereas in axonal degeneration will be distal to proximal change you will be seeing. So the segmental demyelination is the process of degeneration of the myelin sheath with sparing of the nerve axon. So commonly seen in mononeuropathies, sensory motor, principally motor neuropathies, they are often inflammatory and sometimes immune mediated, and around 20% of the symmetric peripheral neuropathies result from damage to the myelin. Examples include Charcot-Marie-Tooth disease and monoclonal gammopathy of unknown significance. So as shown in this diagram, we can see that the axon is intact, whereas the myelin is segmentally damaged or distorted. Second is Valerian degeneration. This occurs after a nerve axon degenerates due to a lesion or a physical compression. Most compression neuropathies, they may undergo this form of degeneration. The portion distal to the axon passively wastes away, likely due to the lack of nutrients from the cell body. As we can see, once the axon is cut through, like injured, the distal flow of axoplasm is not there, so the nutrition to the distal part will be absent. So this will cause wasting of the distal neuron, and this reaction results in focal mononeuropathy that is secondary to trauma or infarction of the nerve. And it is immunohistochemically distinct by a localization of this particular marker, that is neuropeptide YY1 receptor marker, which is very specific for Wallerian degeneration. The third is the axonal degeneration, also called dying back phenomena. As the name implies, it will be a degeneration in the retrograde fashion, and it manifests as symmetric polyneuropathy in around, which is seen in around 80%, and it causes weakness, most notably weakness of the dorsiflexion of the ankle foot with accompanied trophic changes in the muscle. And it can cause, it causes, as I said, retrograde or distal to proximal progression. Most distal portion of the axon is particularly vulnerable to injury because it is at far distance from the axon cell body. So there will be lack of nutritional supply, and so they are at risk of injury. Common etiologies are diabetes, HIV, HCV, and Guillain-Barré. So there is a big list of etiologies for neuropathy, like diabetic, alcohol, nutritional deficiencies like B1, 6, 12, vitamin E, inflammatory condition, hypothyroidism, autoimmune infection, Guillain-Barré, toxins, chemotherapeutic agents, lot of medicines like antibiotic, cardiovascular tumors, paraneoplastic syndromes, inherited disorders, trauma, injury, myelopathy. There are a lot many etiologies, and many times we encounter all of these pathologies. But there is a subtype. If no etiology is found, we label it as idiopathic or cryptogenic sensory polyneuropathy. But this name terminology is given only after extensive workup for all other etiologies of neuropathy. And they typically have a predominant sensory polyneuropathy seen in up to 50% of symptomatic patients. Despite an extensive evaluation, no etiology can be found in these patients. So the common symptoms by these patients include numbness and paresthesia, pain, weakness, or loss of deep tendon reflex, muscle wasting, and autonomic disturbance in the form of fainting spells, orthostatic lightheadedness. That is, on erect posture, suddenly they develop dizziness or giddiness, and orthostatic hypotension without variation in the pulse rate. Usually they develop hypotension, but the pulse rate won't get varied, and heat intolerance, bowel or bladder disturbance. So actually symptoms can be categorized as negative symptoms where there is suppression of the nerve function like numbness, tightness or hyposthesia or warmth and cold and inability to walk or falling like phenomena, or it can present with muscle atrophy, distal weakness, impaired movements, or lack of palmar or plantar sweating or orthostatic hypertension, or it can have a positive symptom with increased neurogenic potentiation like paresthesia, tingling, pain, burning sensation, shooting or paroxysmal pain, allodynia, and cramps, restless leg, fasciculations, or excessive axial sweating. So this neuropathy again, as you can see in this diagram, the nerve will be having a perineurium, epineurium, endoneurium, bundles of nerve fibers, connective tissues, and most important structure, the vasa nervosum, the blood vessels which supply the nerve. It's the vasa nervorum, and also the nerve fibers, and from the nerve fibers, the Schwann cells and the axons we are seeing. So based on this, the neuropathy can be like injury to the, according to the structure involved, it can be axonopathy, myelopathy, or ganglionopathy, or neuropathy, as I already said. And based on the number of neurons, nerves affected, it can be mononeuropathy, polyneuropathy, or mononeuropathy multiplex. Based on the function affected, autonomic neuropathy, motor neuropathy, or sensory neuropathy. Subtype of the nerve fiber affected, it can be small fiber or large fiber neuropathy. And based on anatomical side, it can be radiculopathy or plexopathy. If we see this chart, it will be very confusing, elaborate, like how to approach a patient with neuropathy, like how to go into the history and evaluation. But there are some steps by which we can bypass all these difficulties. So step one is, first we have to identify what elements are affected, whether sensory or motor or autonomic or mixed, like it can be also mixed. So if there is pure motor, then there are very limited differential diagnosis. There is a mnemonic for this pure motor like PHDA, TALL, PHD et al. Like polio, hereditary spinal muscular atrophy, dapsone toxicity, adult variant of exosaminase deficiency, tick bite paralysis, acute intermittent porphyria, lead intoxication, Lambert-Eaton syndrome, and element form of amyotrophic lateral sclerosis. So if the individual is having only motor symptoms, then probably the diagnosis should be within this narrow range. And if it is autonomic alone, then probably the common diseases which have autonomic background are diabetes and amyloid polyneuropathy. So most of the time we can narrow down the diagnosis. But if it is not matching with these two, probably majority of our sensory and mixed. So we can, based on this step, we can identify what type of neuropathy is. And based on the distribution of weakness, if it is present, if there is weakness, then we can identify like if it is symmetrical or asymmetrical, because Symmetrical proximal and distal means it can be Guillain-Barré's or chronic inflammatory demyelinating polyneuropathy. If it is asymmetric, it can be amyotrophic lateral sclerosis or multifocal motor neuropathy. If it is asymmetric motor along with sensory, mostly it should be radiculopathy or flexopathy or compressive neuropathy or mononeuropathy multiplex. These are all the last category actually comes for a neurosurgical group because we do encounter such patients for surgical management. So next is the base nature of the sensory involvement. It can be like loss of sensation, as already said. It can be negative symptom or a change in symptom or a positive symptom, or it can be a positive symptom in the form of tingling, burning, or aching, uncomfortable, spontaneous sensations. And the other most important symptom is a neuropathic pain, which is dull aching, constant nagging pain. It again can be protopathic or epiclitic. Protopathic are those with involving burning, dull, or poorly localized pain, modulated by polymodal C nociceptors, whereas epiclitic pains are sharp lancinating pain related by A delta fibers. So based on the nature of sensory involvement, it can be small fiber neuropathy or large fiber neuropathy. The large fiber neuropathy usually will have associated loss of proprioception, whereas the small fiber neuropathy will have loss of pain and temperature sensory involvement will be there, and the long sensory tract fibers will be intact, like vibration sense will be intact. So mostly small fiber neuropathies are common with diabetes, amyloid, and cryptogenic. The next step is identify whether there is upper motor neuron involvement, because if there is symmetric distal upper motor neuron involvement is there, and whether it is symmetric distal sensory neuropathy with symmetric upper motor neuron sign, the common differences are B12 deficiency, copper deficiency, HIV infection, hepatic disease, or adrenal leukodystrophy. So whenever there is a sensory symptom along with upper motor neuron sign, then we should narrow down the diagnosis to these etiologies. And next step is to identify the temporal evolution, how rapidly the disease has worsened. Like acute, if it happens over days to 1 week or 4 weeks or 1 month, and subacute if it is happening between 1 to 2 months, that is 4 to 8 weeks, and chronic if it is happening over 2 months. So it can have monophasic, progressive, or relapsing. Again, probably some you would have heard in multiple sclerosis, where we can have rapidly progressing or a monophasic single episode coming and go and not repeating, or it can have a relapsing course. So, say example, if it is acute or subacute, with the differentials include Guillain-Barré's, vasculitis, or radiculopathies related to diabetes or Lyme disease. And if it is a relapsing course, then chronic CADP, chronic inflammatory demyelinating polyneuropathy, or porphyria. So again, based on this, we categorize as acute, subacute, and chronic, and symmetry or asymmetry, based on which we can narrow the differential diagnosis. Next step is whether hereditary. By screening the family members, usually they have a slow progressive distal weakness over many years and very little sensory symptoms. But on examination, we'll find a lot of sensory signs, and usually it favors a hereditary neuropathy, and family members will also have similar pathologies. The next is associated medical conditions like diabetes, SLE, or preceding concurrent infection, because GBS is commonly seen with preceding diarrheal illness, or prior surgeries, because gastric surgeries, bypass surgeries can have nutritional neuropathies. We commonly encounter B12 or other nutritional deficiencies. Sometimes medication, example, B6 toxicity also can cause neuropathy. Deficiency also cause neuropathy, and toxicity also cause neuropathy. Alcohol, we all know it causes nutrition deficiency, or dietary habits, or use of dentures, because it can contain zinc, which can lead to copper deficiency. So based on these approaches, we have 9 patterns of neuropathy. So each will have a very narrow differential diagnosis. So if we go analyze the patient, we can identify some pattern of neuropathy, and we can easily come to a conclusion of diagnosis. So it can be symmetric pure motor or asymmetric pure motor involving distal, and symmetric proximal and distal motor with sensory loss, asymmetric proximal distal motor with sensory loss, asymmetric distal motor with sensory loss. So as I read, it might be confusing, but in the subsequent slide, we can differentiate what each indicates, like symmetric distal sensory loss without distal weakness, asymmetric proprioceptive loss without weakness, or autonomic signs and symptoms. So first is symmetric pure motor. If it is only motor and it is symmetric with both proximal and distal weakness, we should consider spinal muscular atrophy. Whereas if it is only involving distal weakness, it is mostly hereditary motor neuropathy or atypical Charcot-Marie-Tooth disease. Next is asymmetric pure motor. It is a pure motor, but asymmetry with more predominant distal. We should consider motor neuron disease. But if it is associated upper motor neuron findings, then it is more in favor of motor neuron disease. though sometimes without upper motor also motor neuron disease can present rarely. But if it is without upper motor neuron findings, then these are the possible differentials. That is progressive muscular atrophy, juvenile molomyelic amyotrophy, that is Hirayama disease. Again, it is our neurosurgeon specialty, and multifocal motor neuropathy and multifocal acquired motor axonopathy. If it is symmetric proximal distal weakness with sensory loss. Now, the earlier two were only motor. The next is if we have associated sensory symptom, but there is symmetric motor weakness, then most common what we almost frequently see is inflammatory conditions, either acute or chronic demyelinating polyneuropathy. The next is asymmetric proximal distal motor weakness with sensory loss. Where whenever asymmetry happens, these are the possible differences like polyradiculopathy or flexopathy of diabetes, meningeal carcinomatosis, lymphomatosis, or hereditary flexopathy or idiopathy. Next is asymmetric distal motor with sensory loss. If there is multiple nerve involvement, we think of multifocal inflammatory polyneuropathy or vasculitis or amyloidosis, sarcoidosis, or infections or tumor infiltration. But if there is involvement of single nerve or region, then we think of compressive mononeuropathy, flexopathy, or radiculopathy. Again, it comes under our neurosurgical perspective, where we have we need to release these nerves for relief of symptoms. So if there is asymmetric distal motor with sensor loss, we need to think these differences. And next is symmetric sensor loss with distal air reflexer with upper motor findings. This is very classical. Whenever there is distal sensory symptom with upper motor finding, then we think of combined system degeneration. That is a combination of corticospinal and long tract sign, where it is common in B12 or vitamin E deficiency, copper deficiency, or hereditary leukodystrophies or adrenomyeloneuropathy. The next pattern is symmetric distal sensory loss with or without distal weakness. Here it is more of sensory symptom. It is symmetric distal sensory and a very minimal motor symptoms. So it is mostly cryptogenic or idiopathic sensory polyneuropathy or diabetes, as we can see the glow and stock distribution of sensory impairment, or other metabolic disorders like drug toxin or hereditary. The next is asymmetric proprioceptive sensory loss without weakness. So here there is asymmetry in the loss of a long tract sign. So we should consider causes of sensory neuronopathy or ganglionopathy, common with cancer, paraneoplastic syndrome, Sjogren's syndrome, or idiopathic sensory neuropathy, and cisplatin induced or vitamin D or toxicity or HIV related sensory neuropathy. The last pattern is if there is associated autonomic symptoms and signs, then we should consider hereditary sensory autonomic neuropathy or amyloidosis, diabetes, idiopathic pan dysautonomia, porphyria, HIV-related autonomic neuropathy, and vincristine chemotherapeutic agent induced neuropathy. So, as we have seen these 9 different patterns, we can see as these 9 patterns were arranged in such a way that it can be motor with sensory, then finally sensory. And in motor also distal and proximal, likewise in sensory also distal and asymmetry or symmetry. So these are the common elements based on which we categorize as neuropathies. Motor, sensory, or autonomic, proximal, distal, symmetrical or asymmetrical. So this motor means the diagnosis becomes narrow to these common differentials. If it is sensory, again it will be wide differential, whereas autonomic has a narrow differential diagnosis. These are all various etiologies for mono and polyneuropathy. So polyneuropathy we have scattered all over the body symptoms, whereas in mononeuropathy we have focused symptoms, and most of the time they happen because of nerve or radicular compression, so like root compression or nerve compression. So when we need come in for the evaluation of where to go for the etiological cause of this pathologist, these are the panel of investigation we routinely do: CBC or metabolic parameters, or vitamin levels, or heavy metal levels, or workup for infection. And thyroid function is a very important test, and antibody specific for some etiologies. Nerve conduction study and imaging studies with MRI or CT based on the location, and nerve biopsy, genetic counseling, genetic testing, and urine test are all the things which we need for evaluation. And usually after these blood investigations, we go for nerve biopsies. But nowadays, nerve biopsies are rarely indicated because most of the time our clinical suspicion and biochemical parameters help in the diagnosis. And a primary indication is mostly if we suspect amyloid neuropathy or vasculitis, nerve biopsy may be needed. Sural nerve is the most commonly biopsied, and it is a pure sensory nerve, so biopsy will not result in the motor function. But when we suspect a vasculitis, this nerve alone may not be sufficient because it will not give the diagnosis. So a combination of the superficial peroneal nerve in addition to the peroneus brevis muscle should be obtained in the same incision. Skin biopsy, again, it is not routinely done, rarely done nowadays, and because it is often required when we suspect the diagnosis of small fiber neuropathy. A punch biopsy of the skin in the lower extremity is sufficient. Based on the density of the nerve fiber, we can make the diagnosis of small fiber neuropathy, and it is done if all other studies are normal. And again, as already said, it is cryptogenic or idiopathic like. So most of the time, it will give only an objective confirmation of the disease, but not much to the added therapy. And most of the time for neuropathies, we have other differentials, say like compressive myelopathies, radiculopathies, autoimmune disease of the CNS or myopathy can cause differentiation. Management, you should focus on the treatment of the underlying etiology, and say like in diabetes, glucose control, in alcohol cessation, and in depleted vitamin supplementation and mineral supplementation, and in disorders of inflammatory immune modulated pathologies, steroid, IV agent, plasmapheresis are I think commonly implemented. Coming to drug therapy, there are some basic analgesics like paracetamol can be given, or membrane stabilizers, or certain antiepileptics and tricyclic antidepressants are in combination given. So anyhow, we will be again discussing in detail of these medications. With regard of prognosis, not all neuropathies are reversible. Generally, demyelinating disorders show a good recovery because remyelination happens in a good way, whereas axonopathies are difficult to treat, and many times physiotherapy and occupational therapy are important for us. And the other good therapy is transcutaneous electrical nerve stimulation for severe pain management. So a word about diabetic neuropathy, because diabetes is one illness which is booming in our country, and probably we see this category as the most important cause for a lot of neuropathy. Most of the time we encounter cryptogenic or diabetic neuropathies, and diabetes can have a lot many varied manifestations. It can involve large fiber also, small fiber, proximal motor neuropathy, acute mononeuropathy, or entrapment, because it can have a variety of symptoms. So anything can happen with diabetes. So in diabetic neuropathy, most of the if it is causing painful, the various drugs we use is first line therapy or anticonvulsants like gabapentin, pregabalin, or antidepressant like amitriptyline and duloxetine. And if they fail, we go for second line therapy like venlafaxine, desvenlafaxine, or opiates like tramadol, tapentadol. The new entry into the market, that is tapentadol, which is showing some promising results. And the topical agents like lidocaine, capsaicin. Also, these are also coming in a big way. Lot many industries are promoting these topical therapies. And third line are SSRIs like citalopram, paroxetine, escitalopram, or opiates like oxycodone, controlled release are used. The small fiber neuropathy, this again is quite frequently encountered form of neuropathy in our OP practice. Pain is by C fiber type and usually causes burning, superficial allodynia, and early hyperesthesia and the hyperalgesia and impaired neurovascular dysfunction. And they cause impaired pain and temperature impairment, and they cause decreased sweating, but other parameters will be normal, like strength, reflexes, and EMG are normal. Next is alcohol neuropathy, again commonly encountered. Common complication of alcoholism, chronic alcoholism, and it causes distal symmetrical polyneuropathy with mixed sensory motor disorder. And pathology is usually axonal loss, and pathogenesis has got both direct alcohol-induced nerve injury and also thiamine deficiency. Neuropathic pain, though neuropathy means peripheral neuropathy, actually neuropathic pain is also a very important field which is often ignored or not concentrated. Rather, it need to be focused. At least in the future generation should focus on the management of neuropathic pain, because pain is a very disabling phenomena. It actually is a condition that results from damage to or dysfunction of the nervous system. It can be central or peripheral. Neuropathic pain is defined as pain caused by lesion or disease of the somatosensory pathway, and it represents a broad category of pain condition as a complication of either peripheral neuropathy or central neuropathy. Also, peripheral neuropathy, when it runs for chronic duration, it can change into a neuropathic pain syndrome. So, in peripheral neuropathy, neuropathic pain syndrome also need to be taken into consideration. And neuropathic pain is one of the most disabling disorders for the patient, and also difficult for the physicians to treat, because they are very resistant to medical management, and it is a big challenge for surgeons also, because it is present in around 8% of the general population. So it's a very disabling pathology. So as lot many phrases are written by many people. The pain is the pain of the mind is worse than the pain of the body, as I said. And another saying is like, nothing begins and nothing ends that is not paid with the moon. For we are born in others' pain and perish in our own. So for all the happiness mankind can gain is not in pleasure but relief of pain. So pain is a very important phenomena. We all wish to have a painless, comfortable life. So examples of neuropathic pain symptoms are, it can be due to peripheral neuropathic pain like peripheral neuropathy, diabetic, alcoholic, or radiculopathy, or traumatic nerve lesion, or post-surgical, or it can be central neuropathic pain after stroke or spinal cord injury or in multiple sclerosis, or it can again be mixed like complex partial nerve pain syndrome. Very common and very difficult to treat syndrome, complex partial pain syndrome. This is the diagram showing that pain pathology can start from anywhere, like peripheral fibers or ganglion or spinal cord or brain. Where the pathology of pain pathway can happen at any level, where everywhere it will alter the balance between activation and suppression, and it causes increased excitation and decrease inhibitory tone, and causes excessive pain sensitivity. So in neuropathic pain, the symptoms can be again positive symptoms or negative symptoms, as like in neuropathy. So like positive symptoms like paroxysmal pain, superficial pain, deep pain, paresthesia, or evoked pain like deep hyperalgesia, punctate hyperalgesia, or mechanical allodynia. And negative symptoms like hypolgesia, tactile hyposthesia, and thermal hyposthesia and punctate hyposthesia. And this is to show what are the nerve fiber controlling all these functions. And again, the neuropathic pain can be categorized various ways, like traumatic or complex pain, regional pain syndrome, or neuromuscular, neurological, metabolic, chronic, cancer-related, or genetic. This again, nerve damage the pathophysiology can be by many methods involving lot many channels and neuronal circuits. Approach to neuropathic pain, like initially we continue with medical management, and most of the time we go to nerve blocks or surgical management at the later course of illness when we encounter such patients. So medical management usually with membrane stabilizing agents, like sometimes we do use steroids or the membrane stabilizing drugs like lidocaine, mexiletine, or antiepileptics like carbazepine, oxcarbazepine, phenytoin, valproate, or drugs that enhance dorsal inhibition like GABA agonists like baclofen, or antiepileptic like clonazepam, gabapentin, or antidepressants. So management of this neuropathic has got both medical and surgical. Medical, as already said, medications, and nowadays electrical nerve stimulation and phytochemicals are coming in a big way, promoting management of this difficult to treat neuropathic pain. And again, surgical also is under research, but probably it needs focus, and it needs contribution from the younger generation to focus on management of this neuropathic pain, because it has though difficulties are there, but it might turn out to be a good hope for our future research. With regard of medical management, as already said, first line gabapentinoids, tricyclic antidepressants, and selective neural reuptake inhibitors like duloxetine, and second line by opioids with the tramadol, tapentadol. The dose of all these are given, and third line with strong opioids or neurotoxin, that is botulinum toxin, also is being used. And nerve blocks, it is used where we try to block a particular nerve with anesthetic agents like lignocaine or bupivacaine or opiocaine. Or sometimes we also try to block the nerve irreversibly with chemical agents like glycerin, or phenol, or alcohol. Or sometimes we do use radio frequency ablation. A few examples are like peripheral nerve lysis by for peripheral neuropathic pain, or for trigeminal neuralgia we do use this technique. Surgical management, it can be lesional procedures, modulated procedures, or others. Where in lesional procedures, dorsal root in entry zone lesioning is a very important thing to be known. Though it has got its own difficulty based on the outcome, but still at least we neurosurgeons need to try to give some hope to those patients who are really suffering from neuropathic pain, and other lesion pathologies like surgeries like neurectomies, or percutaneous lysis, image-guided tracheotomy or nucleotomy are all being given. And for neuromodulation, spinal cord stimulation, peripheral nerve stimulation, motor cortex stimulation, cranial nerve stimulation, deep brain stimulations are nowadays being research are being done and being regularly done. And other therapy like microvascular decompression or intrathecal baclofen therapy are being used. This is the pain pathway and various locations where we are trying to destroy this tract for release of pain. So when coming to surgeries for neuropathy, it can be like peripheral cranial neurectomies, or it can be focusing on the posterior roots, like sectioning of the nerve roots called rhizotomy. It can be done in spinal cord, middle cranial fossa, posterior cranial fossa, or intrathecal injections blocking the posterior nerve roots with chemical rhizotomy with phenol, alcohol, glycerol, or cold saline, or sympathetic chain can be attacked with sympathectomy, or spinal cord may be used as a target where dorsal root injury zones are lesion, or we can focus on spinothalamic tractotomy, or which can be done by either open or percutaneous, or commissural myelotomy, or the other thing like in the medulla, it can be like the medullary spinothalamic tractotomy, trigeminal tractotomy, in midbrain mesencephalic spinothalamic tractotomy, or in thalamus stereotatic thalamotomy, or in hypothalamus post-median hypothalamotomy, or in sensory cortex ablation of the sensory cortex, or in frontal lobe prefrontal leucotomy, lobotomy, cingulotomy, and basofrontal tractotomy or fornix section. Sir, it's not. And non-destructive procedures like transcutaneous nerve stimulation, acupuncture, dorsal cord stimulation, periatrial grade stimulation, thalamic stimulation, or spinal and intraventricular morphine therapies. This is a diagram to show dorsal root entry zone lesioning, where you can see in the dorsal cord, excluding this dorsal tract, that is the posterolateral column tract, we do see the nerve roots exiting out to the tract of Lisar, and lesioning using either bipolar or radiofrequency techniques. But for around 2 millimeters, this lesioning is done. This is another technique called transcutaneous electrical stimulation, which is based on the gate control theory proposed by Melzack and Wall. And here, stimulation are given like this. Also, this is the basis for acupuncture therapy, whereby stimulation of some group, that is motor neurons, alpha motor neurons with low frequency, it will cause stimulation. It will cause release of endogenous opioids, and thereby it will cause suppression of the pain. So it causes inhibition of nociceptive message transmission through the tract by this gate control mechanism. So this also is being nowadays used. So thank you, sir. These are the various surgical treatment we are used in neuropathy, sir. Neuropathic pain, sir. Thank you, sir.
Thank you, Shanthanam. It was a nice lecture.
Sir, your voice is not clear, sir.
Shall I make a comment?
Yeah.
Doctor, it was a very nice presentation, Dr. Shanthanam. You have made it complex subject very simple.
Sir, yes, sir.
Easily could be understood, and clinical approach you have emphasized very nicely.
Sir.
I was little bit, this thing probably I thought you will also deal with the nerve conduction, electrophysiology in electrophysiology of peripheral neuropathy, because that is commonly seen, encountered. We also see the lot of electrophysiology reports.
Yes, sir.
So we must know how to interpret electrophysiology also. Main difference is you have to differentiate between axonopathy and myelopathy.
Yes, sir.
Yeah, myelopathy, you have the velocity is prolonged,
Yes,
and also F wave is prolonged latency. F wave latency is prolonged.
Yes.
Whereas in axonopathy, the amplitude itself is small.
Yes.
So you have to, that only is the main difference between axonopathy and peripheral neuropathy.
Yes.
And secondly, the differential diagnosis probably many times we see cervical spondylotic myelopathy presenting with peripheral, typical glove and stocking anesthesia.
Yes,
we don't know the exact reason. Various theories are postulated, but this is one of the things. And also the syringomyelia many times presents with exactly peripheral neuropathy like picture. So one has to keep it in the differential. These also, whenever you see a peripheral neuropathy, and rule it out also. Otherwise, it's an excellent lecture. Thank you.
Thank you. Thank you, sir. Thank you.
Shanthanam, please stop the sharing of the screen.
Yes, sir. Yes, sir.
Questions can be started discussing 2 to 3 questions. By the time we will ask our questions for the postgraduate students, I request Naveen to put the first question. Quiz on the neuropathy. The first question is, what percentage of diabetic patients develop neuropathy in their lifetime? 10, 30, 50, 80. Okay. Now we can go for discussion. Any doubts? Any doubts, the PG students, or any comments from our members? If there are no questions, the only thing I request all of you is please enter your name, your registration number, your email ID, and your WhatsApp number in the chat box, so that we will be able to get you the credit hours. That is the main thing. All of you, please register your name, the TNMC registration number, the phone number, and the email ID. If there are no questions, I request our next speaker to be ready. And Naveen, can you put the slide?
Yes, sir.
Our Dr. Thiruppathy is going to give a talk on medico-legal aspects and overview. Dr. Subaya Thiruppathy is graduated from Tanjore Medical College, MCH from Madurai Medical College, and microsurgical training in James and fellowship in KIM Hospital, Mumbai, and Fujita Health University. And he has got a number of publications and presentations. At present, senior consultant and neurosurgeon at Thiruchirappalli in ABC Hospital and Apollo Specialty Hospital. And he is doing a lot of activities about these the medico-legal aspects and about the road traffic accident and all the things. He has got a postgraduate diploma in medical law and ethics from NLSIU Bangalore. That's why he is one of our person who is very strong in the medico-legal aspects. So I request Dr. Thiruppathy sir to give his lecture.
Okay, thank you.
Before that, we will have the second question now. Second question, please. Naveen, please put it. Most common cause of mononeuropathy is? Okay.
Can I start, Ajay sir?
Yes,
Can I
sir.
start,
You
sir?
start.
Share screen. Just a minute. Okay, just okay. Okay, my screen is viewed, sir.
Yes, sir. Visible, sir.
Thank you. Thank you, one and all. Nice to meet you after a long time, everybody. Last few days before, our president called me and he told me and he instructed me, actually, rather than told me, he instructed me to share some, so that we have some knowledge about the medical aspects with our members, so that we can move along with the safe practice. Safe practice or practice with a clarity. Okay? So we may be a good surgeons, good academicians. Any player may be a good player, technically sound, but it all depends upon the ground, pitches, what we play, the climate also. Not only the individual efficiency or matters, it also matters about other things where we are, the area of performance is there. So, fortunately and unfortunately, or unfortunately, we cannot avoid the medical legal climate, which is the order of the day and is going to be in ever order of the day. So this is my talk on first talk on a series of talks to have some discussions rather than to have some clarity to move forward. This is the first of it. And I think we can have a good discussion also on that lines. And okay, let us understand the basics. I think maybe I'm reiterating the basics which we all know, but to come to a view of a consolidated view, we need to have reiterate and revisit our basics. So the health system is functioning upon, just you should understand, this is what, where it comes a role play. Demand, supply, health production, financing and government. Everybody is a players here. And altogether, everybody comes to finally to our people. And we are also part of the people. Demand may be from citizens and patients. Supply is by the personal providers, health institutions, health education, health protection of environmental safety, workplace, blood and medical devices, financing and government. In every area, there is a role of legality to play here. Please understand this. So this generally comes from our basics. You should understand why patients come to us, basically. They have to understand that. Because somebody cannot coordinate ongoing symptoms. Someone else is noticing a specific problem like proptosis. Another doctor noticing a specific problem like facial weakness. Worrying about the underlying diagnosis often induced by relatives, friends, books, media, and internet. Spouse or relative worried about the patient, cannot work with symptoms. Colleagues, bosses complaining about patient's work or time off, and requirement of others like insurance, employment benefit, litigation. So patient expectations is very important. High standard of care, behavior and care. They will be because what they expect, they will be consulted about the decisions bearing on the treatment. They will be informed about their illness. They will be informed about the likely outcome of any treatment offered, and their right to confidentiality will be respected. These are the, by and large, 99% patient expectations to us, which we have to keep in mind, which we know, but I'm consolidating here. This slide I want to focus for a few minutes. The problems, what we face here. These are the real problems which we face in the pitch. That's a pitch problems which we face in a practice. A personal economic burden definitely is there. Professional malpractice, we cannot ignore that. Lack of confidence in skills and outcome, both from patients as from doctors per se. Commercialization of medical education and profession, yes. Unethical practices, that is also going on. Negligence, yes. Please understand, one thing I want to put it here is, most of the negligent suits which have been won in India are posted by the doctors and doctor families against doctors. This is an important point you should note. Most of the doctors were convicted were from the cases which were being litigated by doctors and doctors' families. Professional stress, poor communication. This is very important. That's a real problem. Excess and improper information. That is also a concern. Marketing and advertisement. More intermediaries in the profession. வள்ளுவரே 4 பேர் தான் சொன்னார். மருந்து உற்றவன் தீர்ப்பான் மருந்து உலை செல்வான் 4 பேர் தான். Now we have made many intermediaries like managers, marketing persons, many persons, and of course lawyers into the profession. There are alternate medical options. There's increasing health cost, misuse in technological advances in diagnosis and therapeutics. There's a competitiveness and professional rivalry, which we cannot ignore. It's prevalent and it's increasing. Patients are becoming impatient patients. There's intolerant public attitude, which escalated rate violences, consumerism, yes, and political infringement, which we face day and out, some way or other, and we tend to practice a defensive medicine. So these are the problems. See, let us not fear of the problems. These are the existing scenarios which we address, we focus as a problems. Let us see how we can solve. These problems cannot be addressed individually. And for that problems, we need legality to our side also. We say that legality cannot be, we always think that legality means they are coming into, they are only threatening us. Actually, more sense, the legality actually protects us in many problems also. We should, it's a double-edged sword, which we should use it properly. This is a very important thing I want to say here. Health spending. There is an insurance, private and government, and free treatment is also going on out of the package spending. This is very, very important in Indian scenario. See, this is the persons, nowadays our persons are spending from the packet is more here. Because they say that every few lakhs of people are sent to poverty every year, the government says. And India, almost 50-60% of the people spend from the packet for healthcare expenditure. That makes them more, they mortgage or they go for loans, pay loans, and they are pushed to poverty. This is a scenario which we should understand in our climate. Next, this is value. Value of what? How does the medical profession value this? It is equal to the numerator quality and service, and denominator is a cost. This is how any paradigm of medical service is being valued. This is a Pharma. See, whether increase the quality, what is the service, or decrease the cost. You would balance between these three so that we can have an effective way of delivering our healthcare services. Everything changed because Consumerism Act from 1996. 1996, when after this BP Shanta versus IMA, actually it is what we took to நம்மளே ரோட்ல போற ஆளை வந்து நானும் ரவுடி தான் வடிவேல் சொல்லுவாங்கல்ல அந்த மாதிரி நம்மளே உள்ள சேர்த்துக்கிட்ட விஷயம் அது actually. And thus I'll come to later if on some other talk. Let's not talk here. How we got ourselves into a trap. Let us not get to the trap again. That was here. And this is a subject of discussion in some other talk, some other period. So, what is to be addressed? From patient side, their autonomy, safety, and their rights. And don't forget, doctors also have their autonomy. They also conserve their safety. That's one thing. Third thing is, it is from our side. Responsibility, accountability, liability, immunity. These are the things which we have to address as an individual, institutional, or as an organization. Somewhere we have to get into these three paradigms: a responsibility, service, accountability, a liability, or immunity, what we have in this. So, with this, how can we proceed? வள்ளுவருக்கே அதுக்கு பிரச்சனை. ஒரு விஷயத்தை தெளிவில் தொடங்க மாட்டாங்களா? நம்மளுக்கு ஏதாவது பிரச்சனை வந்துருமோன்னு நினைக்கிறப்ப nobody will move forward. இன்னைக்கு 2000 வருஷமா இருக்கிற பிரச்சனை, இன்னைக்கு உள்ள பிரச்சனை கிடையாது. தெளிவில் அதனை தொடங்க இழிவென்னும் ஏதப்பாடு அஞ்சுபவர் அப்படின்னு வள்ளுவர் சொல்றார். So, what does law do? We all know that law cannot make an ill person healthy. Law cannot cure a disease. Law cannot reduce the sufferings. Law cannot remove the ailments. Then why law? That's what is the law. Why does law stand here then? This is our general feeling about law. Sorry. So, just I will enumerate just the role of law where it plays. See, role of law, one law is it can make an attempt to provide for the creation and maintenance of condition in which such measures may be promoted or maintained. At least the impediments to health may be removed. Environmental pollution, public nuisance, preventing spread of certain diseases, for these to create a good climate for health, law is required. Number two, can take care of institutions and personnel engaged in healthcare so that they function with the maximum efficiency. Legislation that regulates the medical and professions and healthcare facilities. This is number 2 of law. Number 3, to prescribe principles upon which failure by a healthcare person to discharge his or her duties properly may be visited with appropriate legal sanctions like medical negligences. And role of law again is to take note of the fact that ill health, physical or mental, may give rise to certain problems at the interest of a person other than that of ill person involved. Like that, matrimonial legislations, spouse with a mental incompetence or sexually transmitted diseases. And drugs. Regulations regarding substances, preparation of techniques used in healthcare. Drugs, devices, the quality control, everything law has to play a role in here. And to ensure that various legal measures are in a place and properly formulated and administered, or that law is required. We want a reasonable, fair atmosphere where we can go with some regulations, like a constitution of country. Yes, that is also law. So what this thing is, hey, I don't care about law. Nobody can say that. Ignorance of law is not an excuse. Ignorance of law excuses no one. This is a maxim which we have to keep in mind. Ignorance of law is not an excuse. Ignorance of a law excuses no one. So this is even our code of ethics say that these are the laws of the country which you should be aware. These are the laws. It is taken from our the ethics, what we have signed, taking with the profession. So we cannot go out of it. So Indian Constitution gives Article 21. So health is a fundamental right. It's a fundamental. It's a right to life and right to personal liberty. And directive principles say that directive principles is to the state governments. States that improving healthcare of citizens as one of the duties of the government. To mean the right of life as a right to live with dignity, including access to the basic healthcare as a right. This is constitutional, which nobody can say we cannot evade from it. So we do have a professional regulations, which everybody know. Now it is renamed as National Medical Commission, which everybody knows, aware of it. So this doesn't end with doctors alone. Every person has some regulation authority, regulatory bodies to get into this. Doctors should have MCA registration regulations, nurses to get registered, and pharmacists, they have their own registration, and they have to be enlisted with the state controller, and parameters and technicians, pertinent qualification and valid experience should be there. This staffs, every medical staff has to be come into a legal ambit somewhere or other. See, I just take through a hospital scenario which all laws, pertaining laws, regulations plays throughout an hospital scenario. When you go to the OP department, no things are ruled by law. Clinical Establishment Act. That's a different debate. We'll discuss later. And presence of a third party should be ensured. This is very important. This is mandated by law. In the following situation, because some female patient, some person should be there. An examination, while examining a private person, female, an examining victim of a rape, the OP department is regulations mandates us. Emergency situations, Honorable Supreme Court directive is there. So that every case has to be attended. We cannot, anybody can admit any patient to emergency. The person who is being admitted, who is admitting cannot be held. That is that clear guidelines Supreme Court has given. And again, Clinical Establishment Act goes. And ICU, how to be ICU in ethics. Honorable Supreme Court has given a directive. And I wish you to, just I'm giving an overview. Just you can check on that lines. In OT, which are the legal sanctions, where are the things are being pertaining here are Narcotic Drugs and Psychotropic Substance Act, Surgery Safety Checklist, OT register, tissue register, and this is very important, which often sometimes we miss over here. Please understand. Also, third part, administration of anesthesia to female. female, we ensure that some third party is there. This most times we miss here. And women health, and we know that many things, mental benefit, MTP, PCP entity, surrogacy and all, women health, some loss goes there. Psychiatric admissions, mental health act is there. Organ transplantation act as its play. Because neurosurgeons, we are dealing with the brain death patients, we are involved in this organ transplantation exercise. So we should have some idea about the transplantation act. And pharmacy, drugs and cosmetic acts, narcotics, drugs and psychotropic substance act, and poisons, and implants. This is very important. This is very, very misunderstood. Implants. See, we see that what I would say, I will reinforce again. Some we have been on the daily basis, in the consignment basis, instruments are there. The implants we are getting. Most of the implants, they have become more just a box autoclave. Now they use some problems occurs, we are responsible. And the CE sticker and sticker would as proper regulation. Otherwise, we are in deep trouble. Implants. And commercial tax regulations also plays a role. Lab and blood bank, that's own regulations. Scans. Please understand, PCP Act, we should get the Atomic Energy Act. Plays a role in hospital rules. And weighing machines. Ordinary weighing machines in the hospitals are bounded legally. The Standards of Weights and Measures Act 1976. And home rehabilitation has its own legal ambits, like Clinical Establishment Act, contractual terms or conditions, obligations, telemedicine. Nowadays, it is picked up after Corona period. NMC has given guidelines. Information Technology Act. We should know the Information Technology Act. And Drugs and Cosmetic Acts also plays a role. EDP. Every hospital has an EDP. We should know the Information Technology Act. Medical record maintenance is very important. How many years, in what way, what all should be there. And health insurance. Now insurance is becoming a big way. IRD Act, Service Level Agreement, Network Hospitals, MOUs, Memorandum of Agreements, what do you have? Health tourism, nowadays picking up. Abroad patients, how to deal with them. So everywhere, somewhere or other, we get and conduct of courses, NMC guidelines, DNB or universities. Now CMA created was what we apply now, get it here. Condition of care, NABH accreditations, clinical research and trials. We should have some these guidelines and drugs and cosmetics, everything comes into play. Research publications, which should undergo. We know that a few years back, one of our top Indian surgeons got into this problem. The approval for research publications, he was not able to got it clear, and there was a phenomenal paper which we were practicing, but he didn't do that. He was put into trouble. I don't want to mention him, everybody knows, but he has done a wonderful work, but still he was caught into the mess, which you are aware of this. And promotional activities, Code of Medical Ethics and Magical Remedies Act. We cure, we discharge within a day, we give a magical remedies advertisements we are increasingly doing now, which is very offense, which we should know. And even sponsors like conferences, there's a Code of Medical Ethics is there, how to sponsor them, that is also there. And hospital administrators and marketing personnel, they have common law and Code of Medical Ethics and magical remedies, which we have claimed. We say that. Trigeminal neurology, I've seen advertisement as Mugavaliki Mutrupulli. These, if somebody penalizes, we are liable. Please understand. Magical remedies we cannot proclaim. And notifications. Please understand why I want to emphasize here. If you are ever getting a tuberculosis spine, it's a notifiable disease. It is our duty to notify to the health authorities. Tuberculosis spine, a tuberculoma, TB meningitis, it's a notifiable disease. And I think how often we do, that is the biggest question. And statutory obligation, environmental laws, biomedical based, it's a big thing now. And dietary and catering, our patients are being served in the hospitals. And Food and Safety Standards Act plays a role. Hospital securities we are nowadays employing. They also come under some acts to regulate. It is there. And others also, fire safety norms, local regulations, construction norms, infrastructure, labor laws. Labor laws is also there. So it is, we may think it is exhausting, but we would always think that these are there to have a smooth run and a reliable run, safety run for the healthcare deliveries. And we should have an idea about that and to take the advantages of that and properly adhere to the reasonable extent to get out of this. And these things, some things you should know when it goes further, Evidence and Limitation Act, so I don't want to bombard with that. Okay. Now, so medical legal, so okay, laws are good, something has happened. So people can take a remedy. It's not only doctors. The establishment, what we work, where, how we perform. Remedies can be classified into 3 types. For a civil law, criminal law, and miscellaneous. Please understand, for civil law, you can sue for damages, for a tort law, or breach of contract, or a compensation under Consumer Protection Act. These comes in civil matters. Criminal law, sometimes a prosecution, complaint for prosecution, criminal law. And PRB is a professional regulatory bodies where Indian medical can seek a remedy from the medical councils. But one thing which I want to emphasize here is the medical council actually now elections are there. The advertisement as if association, Rotary Club advertisement, they are campaigning. It is not a Rotary Club here. It is a professional regulatory body which forms a bridge between the patient and doctors. Which I really astonished to know that it is being propagated, campaign as though it is like an association or a Rotary Association and take care of the doctors. That is not, cannot do that. It's a professional regulatory body which we have to keep in mind. So, civil law, damages, you can get compensations. Criminal law, damages or imprisonment. Professional regulatory body can have suspensions or termination. These are the judgments, can be consequential judgments, can be levied on us. So, what is the impact in neuropsychiatric practice? First, I'll come with a positive note. In the consumer law and the law இல்லைன்னு வச்சுங்களேன், நம்மள ஒரு பய ஒப்பீனியன் கூட கூப்பிட மாட்டோம். இன்னைக்கு ஒரு ஹெட் இன்ஜுரி ஆச்சுன்னா, அது ஸ்கேல்ப் இன்ஜுரி ஆனாலும் சரி, ஒரு நியூரோசர்ஜன் ஒப்பீனியனுக்காக நம்மளை கூப்பிடுறாங்கன்னா, because the law is there. Because the negligence பயந்து. இப்போ சரி வச்சுக்கோ, அந்த லாவே இல்லைன்னு வச்சுக்கோமே, எல்லாம் சிடிஎஃப் பண்ணிட்டு பேடா பேஷண்ட்க்கு ரொம்ப மோசமானதுக்கு அப்புறம் தான் யூ பி கால். அவங்க they will read in the patients. உங்களுக்கு ஒப்பீனியன் ஒழுங்கா கேட்டு உங்களை பண்றாங்கன்னா the law gives you the path. That's the first point. That's a very, very important point. Please, I think everybody to take this in mind. 2 things in this. Medical legal cases, because we are known as trauma care. How to handle a medical legal case? That's one point. Number 2, when you mishandle something, we are put to medical legal cases. Hope you understand that point. How to handle a medical legal case? If you are mishandling something, how we are going to be we are put into medical legal case. These 2 aspects are there for a neurosurgeon. So medical legal case, what I would suggest a checklist here is Axonal register should be 3 copies. I will see the cost, the alleged cost. Add the word alleged cost. சொல்லப்படுகிறது. Many cases we have seen, they have been assaulted and RT and admitted. This is not our problem. We are only expert witnesses. We are not eyewitnesses. So please discharge summary முதற்கொண்டு உங்க எல்லாத்துலயும் ஒரே வார்த்தை alleged to have RTA. Many areas I am feeling that, and alleging the word is very important, which is missing. I wish everybody to take note of it. And information to be relatives. You have to record other possessions immediately. அந்த அடிபட்டு வந்திருப்பாங்க, வந்திருக்கிறப்ப அந்த நகை போட்டிருப்பாங்க, வாட்ச் போட்டிருப்பாங்க, உடனே நீங்க திருடிட்டீங்கப்பாங்க. That is the biggest problem which you have. ஹாஸ்பிட்டல்ல கொடுத்துடணும்னு சார் பார்க்குறப்ப, ஸோ இமீடியட்டா அவங்க என்னென்ன ப்ரொசஸ் பண்ணி அன்கான்ஷியஸ் பேஷண்டோ அதெல்லாம் எடுத்து இமீடியட்டா அதை சீல் பண்ணி, ப்ளீஸ் இன்ஸ்ட்ரக்ட் யுவர் ஸ்டாஃப்ஸ் டு டூ தட். police intimation கொடுக்கணும் admission அப்ப discharge அப்ப death definite if you don't Dr. Rajesh Babu sir, hello president permission president அப்பப்போ தமிழ்லயும் பேசிக்கிறேன் சரியா?
Yeah, sure.
Sure, please. And discharge summary has to be given. And ஒரு விஷயத்தை நான் ரொம்ப தெளிவா சொல்றேன், discharge summaryல எல்லா பக்கத்திலையும் கையெழுத்து. ஏன்னா I have an experience. First page மட்டும் லஞ்சம் கொடுத்து மாத்திடுறான். நம்ம கடைசி பக்கத்தை கையெழுத்து போடும். ஒரு பேஷண்ட் வந்து ஆல்கஹால் எடுத்துக்கான்னு மென்ஷன் பண்ணியிருக்கிறேன். கோர்ட்டுக்கு when you go for MCOP courts, what happens is அந்த ஃபர்ஸ்ட் பேஜ் லஞ்சம் கொடுத்து நம்ம ஹாஸ்பிட்டல்ல ஃபர்ஸ்ட் பேஜ் மட்டும் மாத்திடுறாங்க அந்த வேர்டை எடுத்துட்டு. நான் கொடுத்த சம்மரியில் ஆல்கஹால் இருக்கு, அவங்க கோர்ட்ல இருக்க சம்மரியில வந்து ஆல்கஹால் இல்லாமல் இருக்கு. ஜட்ஜஸ் ஆஸ்க் மீ, என்ன சார் 2 சம்மரி கொடுப்பீங்களான்னு நம்மள கேட்கறாங்க. Then I said, I apologize, it's our fault. Some miscreances happened. I apologize. That's all. And please note that every discharge summary, like every page is signed பண்ணி seal வைங்க. Last page மட்டும் பண்றதா நம்ம பண்றோம். Don't do that. Certificates, wound disability health certificates. இன்னொரு விஷயம் நான் சொல்றேன், நம்ம பார்க்காத கேஸுக்கு don't give disability certificate. That is the biggest problem which we face. Most of doctors do that. And others get a multi of money. You are thrown pennies of few thousands to get it done. அவங்க சொல்ற percentage போட்டு பண்றது நம்ம டாக்டர்ஸ் இந்த தயாரா இருக்கு. Let us make as a practice. நம்ம பார்த்த கேஸ்க்கு, நம்ம இன்வால்வ் ஆன கேஸ்க்கு மட்டும்தான் disability certificate விதிக்கும். This is very, very important. Postmortem அனுப்புறப்ப கேஷீட்டோட காப்பி போயிடணும். ஒரு விஷயத்தை வந்து அந்த கேஷீட் காப்பிக்கு முன்னாடி டிஸ்சார்ஜ் சம்மரியும் வச்சு அனுப்பணும். That is very important because பெரும்பாலும் போஸ்ட்மார்ட்டம் என்ன சொல்றாங்கன்னா, கேஷீட் போல டிஸ்சார்ஜ் சம்மரி ஒழுங்கா இருந்தா பெருசா there's no issues. And டெத்தான கேஸுக்கு கோர்ட்டுக்கு போறப்ப what I would suggest is get the copy of the postmortem report. உங்க ஏதாவது டிஸ்கிரிபன்சிஸ் இருந்துச்சுன்னா அங்கே சார்ட் பண்ணிட்டு அதுக்கு எக்ஸ்பிளேஷன் தயார் பண்ணிட்டு போயிடணும். இல்லையா எனி கேஸ் டெத்தான கேஸுக்கு கோர்ட்டுக்கு அப்பியர் ஆகிறப்பல இருந்தோம்னா ப்ளீஸ் கெட் தி காப்பி ஆஃப் தி. அதே மாதிரி கோர்ட் சம்மன்ஸை வந்து தயவு செய்து போஸ்ட்ல வாங்க. டோன்ட் கெட் பை போஸ்ட் பிகாஸ் நம்ம டேட்டு தெரியல. இன்னொன்று விஷயம் வந்து அவங்க பேஷண்ட் பேரை மட்டும் எழுதி அனுப்புறாங்க. எந்த பேஷண்ட் நம்மளுக்கு தெரியாது, எந்த வருஷமும் தெரியாது. ரிசீவ் ஆச்சு நம்ம போய் சொல்லிட்டு வரோம். நம்ம போய் சொல்லிட்டு இல்லை சார் எனக்கு தெரியல, எந்த பேஷண்ட் தெரியல சொல்லிட்டு வரோம். இதை விட முக்கியமான பிரச்சனை என்ன அப்படின்னா, பேஷண்ட் பேர் கூடாது. அந்த ஒரு பேஷண்ட் இருக்காங்க, அவங்க மோதினவங்க பேர் எதிரின்னு வச்சிருப்பாங்க. Who has done that? ஒரு கார் ஆக்சிடென்ட் பண்ணவங்க எதிரின்னு வச்சுக்கோங்க. இப்போ வந்து ராஜேஷ் பாபுவோட கார் இது வந்து நான் வந்து மோதிட்டேன், நான் மோதிட்டேன்னா எதிரி திருப்பதி சம்பந்தமாக அப்படின்னு கோர்ட்ல சொல்லுவாங்க. யாரு மோதிரம் நமக்கு தெரியுமா? And you don't waste our precious time on this. So any summons from the court by post don't receive because that doesn't have the information what you need. Tell your hospital administrator not to receive it. You have the right to deny. Please understand. Okay, இதெல்லாம் I don't want to. Zonalization கிடையாது. இப்பெல்லாம் எந்த ஊருக்கு வேணா எங்க வேணா பேஷண்ட் அனுப்பலாம். And they will take care. It's not our problem. And this is very important. Emergency admission என்ன பண்ணணும்? This is very important, which we cannot deny. The hospitals in the emergency department should admit a patient whose condition is moribund or serious. If necessary, the patient concerned may be kept in the floor on the trolley beds initially. இது ஒவ்வொன்றையும் நான் சொல்றது ஒவ்வொரு ஜட்மெண்ட்டை வச்சு தான் சொல்றேன். நானா சொல்றேன். ஒவ்வொரு ஜட்மெண்டோட எதை வச்சுதான் just putting forward. Subsequent necessary adjustment should be made by the hospital authority by way of transfer and discharge. Financial consideration is not a factor. Legal patients, please understand. This obligation to sick, which we have taken the oath, we have signed with the regulator with medical ethics. Consent பத்தி நம்ம பேச விரும்பல because that is the next part of our talk. I'm just skipping these slides. Okay. And ஒரு சின்ன பிரச்சனை நம்மள்ட்ட இருக்கு. என்னன்னா கான்ஃபிடென்ஷியாலிட்டி இருக்குல்ல. கான்ஃபிடென்ஷியாலிட்டிங்கிற வேர்டை வந்து வெஸ்டர்ன் கல்ச்சர் வேற, நம்ம கல்ச்சர்ல வேற மாதிரி. அவங்கள பொறுத்தவரைக்கும் பிரைவசி, அவங்க வந்து ஒரு டிசீஸ் இருந்துச்சுன்னா யாருக்குமே தெரியக்கூடாது அப்படின்னு நினைக்கிறத கான்ஃபிடென்ஷியாலிட்டி. ஆனா நம்ம ஊரை பொறுத்த வரைக்கும் டிசீஸ் வந்தா ஊருக்கே தெரியணும், அட்டெண்டர்ஸ் எல்லாருக்கும் தெரியணும். சார் எவ்வளவு சொல்லியிருப்போம் சார், இவங்கள்ட்ட சொல்லிருங்க சார், இவங்கள்ட்ட சொல்லுங்க சார், சார் என் கூட வந்திருக்காங்க அவங்கள்ட்ட சொல்லிருங்க சார், உங்க வாயால சொல்லுங்க சார். அதர்வைஸ் எம்ப்ளாயி யாரு பே பண்றாங்களோ அவன் வந்து நிற்பான், நான் தான் பே பண்றேன் என்கிட்ட சொல்லுங்க. ஸோ ப்ளீஸ் அண்டர்ஸ்டாண்ட், அந்த கான்ஃபிடன்ஸ் சிங்கிள் டேர்ம் ஹஸ் டூ கனோட்டேஷன்ஸ். வெஸ்டர்ன் ஸ்டாண்டர்ட்ஸ் இஸ் த பிரைவசி, நம்ம ஸ்டாண்டர்ட்ஸ் ஃபெய்த், ட்ரஸ்ட் ஆன் us is confidence. Please understand, there's a very big cultural difference here which you should understand, which we can apply. And two interests, adla seri confidentiality privacy nu eduthamna, when western standards padi eduthalum it's a right of individuals and public or private interest nu paakrom. Sila area la we have to disclose areas, ena இந்த மாதிரி areas we have to disclose when the patient or his legal advisor allows it, when it's interest of the patient. ஒரு டிசீஸ்க்காக இன்டிமேஷன் பண்றப்ப சொல்லிதான் ஆகணும். லீகல் டியூட்டி டு டிஸ்க்ளோஸ், அட்மினிஸ்ட்ரேஷன் சில ஒர்க்மேன்ஸ் கன்சூமர் ப்ரொடெக்ஷனுக்கோ ஒர்க்மேன் காம்பன்சேஷனுக்கோ சொல்லிதான் ஆகணும். ப்ரொஃபஷனல் கலீக்ஸ் அலிஸ்ட்டை நம்ம டிஸ்க்ளோஸ் பண்ண தான் செய்யறோம். டீச்சிங் ரிசர்ச்சுக்கு டிஸ்க்ளோஸ் பண்ண தான் செய்யறோம். சம்டைம்ஸ் ஆஃப்டர் டெத் டிஸ்க்ளோஸ் பண்ண தான் செய்யறோம். சில ஏரியாவில் நம்ம தவிர்க்க முடியாது. இங்கே பிரைவசி வயலேஷன்ஸ் இருக்கு. மேபி ஹியூமன் எரர்ல இருக்கலாம், theft, what I said, compromise in electronic systems, நினைக்கிற அக்சஸ் கண்ட்ரோல்ல. ஸோ ரெண்டு பிரைவசி ரெண்டு வகை இருக்கு. ஆட்டோனமி பிரைவசி அண்ட் இன்ஃபர்மேஷனல் பிரைவசி இருக்கு. பெஸ்ட் திங் இஸ் எந்த டாக்குமெண்ட்லையும் கீழே சைன் ஆல் பேஜஸ், சைன் ஆல் பேஜஸ் ப்ளீஸ். ஸோ டிஸ்சார்ஜ் மோட்ஸ் எல்லாருக்கும் தெரியும். டாமா ஏமான் என்ன, அது don't want to explain all this. So routine discharge என்ன, discharge device. What I am saying is give discharge summary. நாம don't deny discharge. அவ்வளவுதான். அதுல நான் இந்த ஸ்லைட்ஸ் நான் பேச விரும்புறேன். I don't want, பட் ஒரு கேள்வி வரும். நைட்டு 12 மணி சார், 2 மணிக்கு சாயங்காலம் தான் பார்த்துட்டு வர்றேன், நைட்டு 1 மணிக்கு நான் வீட்டுக்கு டாமால கூப்பிட்டு போறேங்க, பேஷண்ட் டிஸ்சார்ஜ் கூப்பிட்டு போறேங்க. நம்ம என்ன பண்ணலாம்? ஆக்சுவலி டாமால சட்டப்படி கொடுக்காட்டியும் வாட் ஹேப்பன்ஸ் இஸ், நம்ம ஒரு பேஷண்ட் ரிசீவ் பண்ண முடியும். பார்த்துருப்பீங்க, பல பேஷண்ட்ஸ் வந்து சொல்லுவாங்க, சார் 10 நாள் வச்சிருந்தாங்க சார், ஒண்ணுமே சொல்லலை சார், என்ன நடந்துச்சுன்னே தெரியல சார், ஒண்ணுமே சொல்லலை சார்மா. எவ்ரி பர்சன் சே தி சேம் திங். நீங்க ரிசீவிங் என்ன பண்ணல, நம்மளுக்கு சமயம் சந்தோஷம் இருக்கலாம், அங்கே பண்ணல போல நம்ம தான் பண்ண போறோம். தட் இஸ் அவர் ஹியூமன் நேச்சர். வி ஹேவ் அதர் ஒரு சும்மா ஒரு சின்ன நேச்சர் வி ஆல்சோ ஹேவ், அண்டர்ஸ்டாண்ட். பட் வாட் ஐம் சேயிங் இஸ், நீ நம்மள்கிட்ட சொல்றப்ப நம்ம பேஷண்ட் அப்படிதான் வேற எதையும் போய் சொல்ல போறோம். ஸோ வாட் we have formulated is ஒரு இமீடியட் டிஸ்சார்ஜ் டாக்குமெண்ட் அப்படின்னு ஒன்று தயார் பண்ணி, இமீடியட் டிஸ்சார்ஜ் டாக்குமெண்ட். டியூட்டி டாக்டர் சொல்லி 2 வாரம் டயக்னோசிஸ் மேனேஜ்மெண்ட், இதை பார்த்தாலே தெரிஞ்சு போயிடும் நம்மளுக்கு. ஓ எங்கேயோ தகராறுபட்டு வந்திருக்கிறான் அப்படின்னு தெரிஞ்சு போயிடும். இமீடியட்டா டிஸ்சார்ஜ் கேட்டிருக்கான்னு தெரிஞ்சு போயிடும். ஸோ இந்த டாக்குமெண்ட் நம்ம கொடுத்துட்டோம்னா அவனுக்கு ஒரு டாக்குமெண்ட் நம்மளை கொடுத்துட்டாங்கன்னு தெரியும். அந்த நம்ம மேல தேவையில்லாத ஒரு குற்றச்சாட்டை எங்கேயுமே வைக்கிறது வாய்ப்பு இல்லை. ஸோ இந்த மாதிரி சிம்பிளா 2 வார்த்தைப்பா டயக்னோசிஸ் மேனேஜ்மெண்ட்ப்பா ஏன் பண்ணல, 2 வார்த்தை 4 வார்த்தை எழுதி கொடுத்து அனுப்பியிருப்பா, அது மேல வார்த்தை முக்கியம். இமீடியட் டிஸ்சார்ஜ் டாக்குமெண்ட். ஸோ டிரான்ஸ்போர்ட்டை பொறுத்த வரைக்கும் டிரான்ஸ்போர்ட் இருக்கிற பேஷண்ட்ல ஒரு சிக்கல் வருது. டிரான்ஸ்போர்ட் என்ன பண்றப்ப எந்த பேஷண்ட்டை யார் வந்து சேர்க்கலாங்கிறத நான் ஏற்கனவே சொன்னேன். டிரான்ஸ்போர்ட் நார்ம் வந்து stabilize and shift. Simultaneous documentation should be all inclusive after proper informed consent. Concurrence in the standard format should always be clear in all stages of transfer. In emergent situations, any mode of transport should be accepted in view of want of time. Transfer patient in a car is not negligent. If all possible assistance was given to the patient during the transfer, there is no negligence if ambulance was refused. But there is negligence if the patient was not transferred in a proper way without support necessary. Ambulance இல்ல, ambulance எனக்கு இல்ல என்ன பார்த்து சொல்லலாம். அது because இதெல்லாம் கோர்ட் ஜட்ஜ்மெண்ட் இருக்கிறதுனால I'm putting these things. Please be aware of this. டிரான்ஸ்போர்ட் பண்றப்ப இன்னொரு டிரான்ஸ்போர்ட் இருக்கு நமக்கு. சிடி ஸ்கேனுக்கு எம்ஆர்ஐக்கு சிக் பேஷண்ட் டிரான்ஸ்போர்ட் பண்றோம். நம்மகிட்ட ஃபெசிலிட்டி இல்லை ஹாஸ்பிட்டல் எம்ஆர்ஐக்கு. அப்போ ஒவ்வொரு டிரான்ஸ்போர்ட்லையும் கெட் திஸ் ஃபார்ம் லைக் திஸ் ஹை ரிஸ்க் ஃபார் டிரான்ஸ்போர்ட் அப்படின்னு ஒரு ஃபார்ம்ல கேட்கறாங்க. மோஸ்ட் ஆஃப் தி ப்ராப்ளம்ஸ் ஹேப்பன்ஸ் டூரிங் தி டிரான்ஸ்போர்ட். ஓகே, நெக்லிஜென்ஸ் பத்தி ஜஸ்ட் few slides, few things. Owing to duty of care or breach of said duty on constitutional damage, இது மூணு தான் negligence. Duty of careல breach இருக்கணும். Breach owing a duty of you owe a duty of care. If that care is there is a breach in the duty and அதனால damage ஆனாதான் negligence. Please understand. இது மூணு நடந்தாதான் negligence. Malpractice வேற negligence வேற. ரெண்டையும் போட்டு குழப்பாதீங்க. Malpractice unethical practice. Negligence is different. But negligence malpractice ஒண்ணா நம்ம கன்ஃபியூஸ் பண்ணிக்க கூடாது. நெக்லிஜென்ஸ் இந்த மூணு விஷயமும் இருந்தா மட்டும்தான் நெக்லிஜென்ஸ் ப்ரூவ் பண்ண முடியும். அதுவும் நிக்கும் கேஸ். ஓவிங் யூ ஓவர் டியூட்டி ஆஃப் கேர், பிரீச் ஆஃப் அ செட் டியூட்டி அண்ட் கான்சிக்யூஷனல் டேமேஜ். நெக்லிஜென்ஸ் எக்ஸாம்பிள் நான் சொல்லுவேன். contaminated blood in a blood bank, not providing a post-operative care properly. Participation unqualified person, chemist selling not prescribed doctor, leaving a gauze, இதெல்லாம் negligence. Negligence acts வந்து misrepresenting their own possessive skill. நம்ம சம்பந்தமே இல்லாம வேற யாரும் misrepresent பண்ணி நம்ம சர்வா பேசுறது. Recklessness, indifferent in handling, failure to act diligently appropriate time, wrong side operations, wrong diagnosis, totally wrong diagnosis. அதாவது நம்மளால டோட்டலா ராங் டயக்னோசிஸ் இருந்தா மட்டும்தான். ரிட்டர்ன் கன்சென்ட் எழுதி வாங்கணுங்கிறது நெக்லிஜென்ட் ஆகாது. ஃபர்ஸ்ட் பாயிண்ட். பேஷண்ட்டுக்கு நம்ம பண்றோம், வைத்தியம் கொடுக்கறோம், ரிலீஃப் கிடைக்கல, பெயின் சரியாகல அப்படின்னா அது நெக்லிஜென்ட் கிடையாது. ஒரு டிஸ்க் ஆப்ரேட் பண்றோம், அந்த பெயின் சரியாகலைன்னா அது நெக்லிஜென்ஸ் கிடையாது. ப்ளீஸ் அண்டர்ஸ்டாண்ட். டிசைர் ரிலீஃப் கிடைக்கல, நெக்லிஜென்ஸ் கிடையாது. ஒரு பெட் இருக்கு, சீரியஸ் பேஷண்ட்டுக்கு வேக்கன்ட் பெட் இல்ல, கொடுக்க முடியலன்னா அது நெக்லிஜென்ட் கிடையாது. அப்புறம் எந்த பேஷண்ட் ப்ரிஃபரன்ஸ், முதல் பேஷண்ட்டுக்கு பிரசிடென்ஸ் ஓவர் இந்த பேஷண்ட்டுக்கு முதல்ல பார்த்துட்டீங்கன்னா சொல்றது நெக்லிஜென்ஸ் கிடையாது. ப்ளீஸ் அண்டர்ஸ்டாண்ட். ஸோ திஸ் இஸ் எரர் ஆஃப் ஜட்ஜ்மெண்ட் இஸ் நாட் நெக்லிஜென்ஸ். எரர் ஆஃப் இதுதான் இன்னைக்கு எரர் ஆஃப் ஜட்ஜ்மெண்ட் இஸ் நாட் நெக்லிஜென்ஸ் அட் ஆல். Please understand. The standard of care which the law requires is not an insurance against accidents. It is such a degree of care as a normally skillful member of a profession may reasonably be expected to exercise in actual circumstances of the case. It is not every slip of a mistake which imports negligence. Please understand. So contributory negligence, no follow-up or changing doctors is a contributory negligence because patient is also negligent. Negligence. Patient is also contributory negligence. As of now, proper rules இன்னும் தேவைப்படுது. பிரைவேட் கம்ப்ளைண்ட் வந்து மேஜிஸ்ட்ரேட் எடுத்து இது யாரையும் ஒன்றும் பண்ணிட முடியாது. இன்வெஸ்டிகேட்டிங் ஆஃபீஸர் தானா யாரையும் கைது பண்ண முடியாது, இன்வெஸ்டிகேட் பண்ண முடியாது, இன்னொரு டாக்டர் ஒப்பீனியன் பண்ண முடியாதுன்னு தெளிவா தெரிஞ்சுங்க. They cannot do that. And இது வந்து ஹாஸ்பிட்டலோட liabilities. அது வேணா இன்னொரு தடவை some other occasion, because want of time, some other occasions we will talk on this and talk to liability. Or safe neurosurgical, because want of time, just a nutshell into a safe neurosurgical practice. Documentation of medical records is very important. There is no second thought about this. Second opinion, தயவு செய்து கேட்டுங்க. ஒரு டயலமால கேஸ் செகண்ட் ஒப்பீனியன் நீங்களே பேஷண்ட் வாங்கினாலும் சரி, நம்மளே வாலண்டியரா வாங்கிட்டா பெட்டர். Do as a team work. 2-3 surgeons or 2 surgeons involved is a good thing to practice. Easy to practice and very easy to practice. Implant and devices. Implant failure, surgeon problem. Please understand. But நம்ம எல்லாத்துலயும் வரும், ஷண்ட் டியூப்ல எல்லாத்துலயும் வர்றப்ப அதுல ஸ்டிக்கர்ஸ் வரும். அந்த ஸ்டிக்கரை தூக்கி போட்டுருவாங்க எல்லாமே. அந்த ஸ்டிக்கரை வந்து கேஷீட்லயும் இல்ல சர்ஜிக்கல் நோட்ஸ்லயும் ஒட்டிருங்க. இந்த சிஇ FDA அதெல்லாம் பார்த்துருப்பீங்க. மேக் இன் இந்தியான்னு ஒரு ஸ்டிக்கர் வந்து ப்ராப்பர் இம்ப்ளான்ட்ஸ்லோ டிவைசஸ்லோ இருக்கும். அவங்கள பொறுப்பாக்கணும்னா இது அந்த பேட்ச் நம்பர்லாம் சரியா இருக்கும். அப்ப நம்ம எங்கன்னு தெரியாது. ஸோ அவங்க 3 ஸ்டிக்கர் எல்லாத்துலயும் கொடுத்துருப்பாங்க. 2 காப்பி. அந்த ஒரு ஸ்டிக்கரை எடுத்து கேஸ் ஷீட்ல ப்ளீஸ் பேஸ்ட். இந்த சிம்பிளா நம்ம பார்த்ததே கிடையாது. இது வந்து யூரோப்பியன் ஸ்டாண்டர்ட்ஸ், இது வந்து எஃப்டிஏங்கிற சிங்கிற யூரோப்பியன் ஸ்டாண்டர்ட்ஸ், எஃப்டிஏங்கிறது வந்து யூஎஸ் ஸ்டாண்டர்ட்ஸ் அண்ட் மேக் இன் இந்தியாங்கிறது இப்போ நம்ம இந்தியாவில் வந்துட்டு. ஒரு எக்ஸாம்பிள் நான் சொல்றேன். டெப்போமெட்ரால் எபிடூரல் இன்ஜெக்ஷன் நம்ம போடுறோம். ஆக்சுவலி இட் இஸ் நாட் ஃபார் தி ஸ்பைனல் யூஸ். அதோட யூஸே அட்டையிலே போட்டிருக்காங்க, இன்ட்ராமஸ்குலர் இன்ட்ராஆர்டிகுலர் யூஸ் தான். Anybody can sue us for using depometral preparation for epidural injections. Please understand. It's very gray. Please understand. நம்ம ஏதோ பண்ணிட்டு இருக்கிறோம், அவ்வளவுதான். நீங்க பார்த்திருப்பீங்க, இப்ப ஒரு ஆப்தால் கேஸ்ல கண்ணுக்கு போட்டு 54 பேர் they got into a problem. அப்ப எல்லாரும் வந்து அந்த யூஸ் பண்ண ஆரல்ல தான் ப்ராப்ளம் சொல்லி பாக்ஸ்டர் கம்பெனி மேலேயே அவங்களும் இழுக்க பார்த்தாங்க. அவன் தெளிவா சொல்லிட்டான், ஐவி பாட்டில்ல பாருங்க, இட்ஸ் ஒன்லி யூஸ் ஃபார் ஐவி யூஸ் ஒன்லின்னு எழுதியிருக்கிறேன் பாருங்க. He is not about contamination. He has escaped totally from it. எத்தனை பேர் பார்த்திருப்போம் தெரியல. அந்த only for IV use அப்படின்னு எழுதிருக்கு சின்னதா. Let us be very that and come to hemostats. Please understand, gel foam, surgical என்னென்னமோ வைக்கிறோம். பல இது கிளினிக்கல் ட்ரையல் பேஸ்ல இருக்கு, பலது அப்ரூவல் இல்ல. உள்ள வைக்கிறது வச்சு எடுத்துறோம்னு சில பேர் மேனேஜ் பண்றாங்க. எத்தனை பேர் படிச்சிருப்போம்னு தெரியல. ஜெல் ஃபோம் சில ப்ரிப்பரேஷன்ஸ் எல்லாம் வந்து it is not kept alone. ஒரு டெம்பரரி ஹீமோஸ்டாசிஸ் யூ ஷுட் ரிமூவ் எண்ட் ஆஃப் பிஃபோர் அப்படின்னே இன்ஸ்ட்ரக்ஷன்ஸ் இருக்கும். நம்ம அதெல்லாம் உட்கார்ந்து பார்த்துட்டு இருக்க முடியாது. ஸோ ஆபரேஷன் நோட்ஸ்ல என்ன பண்ணுங்க, திஸ் இஸ் practice worldwide. I've discussed with the worldwide surgeons also. They say it is a problem for us. What they say is hemostasis achieved or hemostasis ensured by what? Gel foam, surgical. Don't write. Don't write. Hemostasis ensured as and when necessary. Hemostasis achieved. அதோட நிப்பாட்டிங்க. Don't go further on that. Tissue diagnosis, டிஸ்க் எடுத்தாலுமே send for diagnosis. நாளைக்கு டிஸ்க், ஏன்னா எம்ஆர்ஐ எடுத்து பார்த்தா டிஸ்க் எடுத்தாலும் எடுக்காத மாதிரி தான் படம் வந்து நிற்கும். அவங்க எடுக்க யாரோ நியூரலாஜிஸ்ட் வந்து ரெசிடுவல் டிஸ்க் இல்லாம டிஸ்க் அப்படியே இருக்குன்னு கொடுத்துருவாங்க ரிப்போர்ட் யாராவது. அப்ப டிஸ்கை நீ எடுக்கலன்னு சீவ் பண்ணலாம். ஸோ டிஸ்கை எடுத்த உடனே ஒரு 300 ரூபாய்க்கு அப்போ தயவு செய்து டோன்ட் கெட் இன்டு தட். சென்ட் இட் ஃபார் பயாப்சி. டியூமர் தான் பயாப்சி எழுப்பணும் கிடையாது. எனி டிஷ்யூ டேக்கன் டேக் அஸ் அ பயாப்சி இட் வில் சென்ட். சர்டிபிகேட்ஸ் எம்எல்சி, எல்லா ட்ராமா கேஸும் எம்எல்சி கொடுத்துருங்க. எம்எல்சி இஸ் இம்யூனிட்டி ஃபார் யூ. ப்ளீஸ் அண்டர்ஸ்டாண்ட் கேஸ். மெடிக்கல் லீகல் கேஸ் போட்டீங்கன்னா நீங்க உங்க மெடிக்கல் லீகல் கேஸ் போட்ட கேஸ்ல நெக்லிஜென்ட் கேஸ் வரவே வராது, தெரியுமா உங்களுக்கு? ஷூ பண்ணவே மாட்டாங்க. ஏன்னா தே நோ தட் எம்எல்சி கேஸ்ல காம்பன்சேஷன் இஸ் a short shot. நெக்லிஜென்ட்ல வருமா இல்லையான்னு தெரியாது. ஸோ நோ லாயர் வில் என்டர்டெயின் நெக்லிஜென்ஸ் rather than எம்எல்சி கேஸ். மெடிக்கல் லீகல் காம்பன்சேஷன் உங்களுக்கு ஈஸி. ஸோ ஆஸ் ஃபார் அஸ் பாசிபிள் பேஷண்ட் சார் நாங்கள் விழுந்துடும் சார், எங்க வண்டி தான் சார், அது நம்ம ப்ராப்ளம் கிடையாது. அவங்க போலீஸ்காரன்ட்டு அவங்க பேசிட்டு போறாங்க. எம்எல்சியா எந்தெந்த ட்ராமாவை கூடிய வரைக்கும் எம்எல்சி அப்படின்னா we are safe in practice. Please understand. தயவு செய்து troublesome கேஸ்ல ஃபீஸை வேவ் பண்ணாங்க. That gives a suspicion. நம்மூரை பொறுத்த வரைக்கும் ஒரு மாப்பிள்ளை வந்து வரதட்சணை வேண்டாம்னா அவட்ட குறை இருக்குன்னு நினைக்கிற ஊர். நீங்க மனிதாபிமான அடிப்படையில சரியா வராத கேஸுக்கு வந்து அதே மாதிரி எந்த ஆக்சிடென்ட் நடந்தாலும் எது பெரிய வண்டியோ அதான் ப்ராப்ளம். இந்த மைண்ட் செட்டை எல்லாம் நம்ம வீட்டுல இருந்து ஜட்ஜ் வரைக்கும் இருக்கு. ஸோ நீங்க வேண்டாம்னு சொன்னா நீங்களே உங்க குற்றத்தை ஒத்துக்கிட்டாப்ல ஆயிரும். ஃபீஸ் பே பண்ணாட்டி ஃபீஸ் எழுதி பண்ணுங்க. அவன் பே பண்ணலன்னு எழுதுங்க. He has not paid the fees. அவன் மேல போடுங்க. Never ever way off the fees from your side. Never ever please way off the fees from your side. And update, learn, unlearn, relearn, publish, present and discuss not only your cases, your complications also. That adds to the kitty to safeguard you. இதுதான் ரெஃபரன்ஸை காமிக்க போறோம், இந்த known complications. அதனால so as for complications is also to be published, presented and discussed. So that is a defense in the future for everybody, for ourselves and our colleagues also. Expertise and experience not only in surgery but choosing your patient is also. This is your right. Emergency இல்லாம வயசு ஆக எக்ஸ்பீரியன்ஸ் எக்ஸ்பர்டைஸ் ஆக even trouble ஆன patient அப்படின்னா don't entertain. கண்டிப்பா we know, we definitely will be knowing as we grow this is a troublesome patient. Don't do that. And please understand, you can deny, it's your right. A physician is free to choose whom he will serve. You can deny. You can even withdraw in the middle of the, withdraw பண்ணிக்கிட்டு அதுக்கு reason out பண்ணி you can withdraw from your service unless emergency situations. Please come out. Please come out. அதாவது வின் பண்ண லூஸ் பண்ண டிரா பண்ணிக்கணும் மேட்ச் அட்லீஸ்ட் அந்த மாதிரி. And intermediate insurances, separate thing. This is very important. We always come law, ethics, morality, mooning kualappikkirom. Immanuel Kant said, in law, a man is guilty when he violates the rights of others. Ethics is guilty if he only thinks of doing so. Morality is not properly doctrine of how we make ourselves happy, how we may make ourselves worthy of happiness. இது மூணு இதை வந்து ஜஸ்ட் இதை உடனே புரியுமான்னு சொல்ல யோசிச்சு பார்த்தீங்கன்னா நெட்ல பார்த்தீங்கன்னா மூணுக்கு டிஃபரன்ஸ் குழப்பிக்க கூடாது நம்ம. அண்ட் பேஷண்ட் ப்ளீஸ், பேஷண்ட் வந்து பேஷண்ட் டெஃபினிஷன் படி இருந்தால் பிரச்சனை கிடையாது. பேஷண்ட்னா அந்த டிக்ஷனரி டெஃபினிஷன், ஏபிள் டு அக்செப்ட் ஆர் டாலரேட் டிலேஸ், ப்ராப்ளம்ஸ் ஆர் சஃபரிங் வித்வுட் பிகமிங் அனார் ஆங்ஷியஸ். அண்ட் டாக்டர் இஸ் அ குவாலிஃபைட் practitioner of medicine, not an expert. He's a practitioner always. Trust me, I am a doctor. Communication coordination is very important. Communication is very, very important. And what ஒரே ஒரு சின்ன எபிசோட் மட்டும் சொல்லிட்டு I finish it, sir. Which my personal experiences சொல்றதா better. 2 minutes can I take, sir?
Yeah, sure, you can. Go ahead.
One of the patient I was operating, one patient was referred to me as bilateral subdural hematoma by a renal physician. Patient walked to my OPD. இந்த சர்ஜரி முடிச்சு நான் அப்படி டயர்டாக வந்தேன். எனக்கு சஸ்பிஷன் வந்து இடியோபதிக் இன்ட்ராக்கில் ஹைப்போடென்ஷனாக இருக்குமா அப்படின்னு ஒரு சஸ்பிஷன். ஹைப்போடென்ஷன் சரி, நீ வந்து எம்ஆர்ஐ அட்மிஷன் போட்டுட்டு, எம்ஆர்ஐ ஹாஸ்பிட்டலில் ஃபெசிலிட்டிஸ் இல்லை, அப்போ நீ எம்ஆர்ஐ மட்டும் பண்ணிட்டு வந்தாங்க. அதுக்கப்புறம் ஐ திங்க் அபவுட் ஆப்ரேஷன், ஐ திங்க் டயக்னோசிஸ் டிஃபரன்ஸ் சொல்லிட்டு பேஷண்ட் அட்மிட் பண்ணிட்டு நான் வீட்டுக்கு சாப்பிட வந்துட்டேன். பேஷண்ட் எம்ஆர்ஐ சூட்டு கூப்பிட்டு போயிருக்காங்க. கொஞ்சம் இரிட்டபிளாக வந்தப்போ they have given some sedation. Patient collapsed at the MRI suit outside the hospital. And he was intubated and brought here. He was arrested. I know that he is not going to survive. Definitely. எனக்கு ஷாக். வீட்டுக்கு வந்துட்டேன். வந்து பார்த்தா என்னடா பேஷண்ட் நடந்து வந்த பேஷண்ட் suddenly is there. Then I went to the scene. I sat. First I sat with the patient attenders. And என்ன இருந்தாலும் அவங்கள்ட்ட, பிகாஸ் அவங்களை அகைன் இருக்க தான் செய்யும். I asked them to vent. I just kept quiet for 40 minutes. 40 minutes I kept quiet. They were, they were, என்ன சொன்னா ஒண்ணுமே பேசல. சரி, இப்போ நீங்க பேசிட்டீங்க, நான் பேசுறதுக்கு 10 minutes டைம் கொடுங்க, அதுக்கப்புறம் நீங்க பேசுங்க. இப்போ எனக்குமே ஷாக்காக தான் இருக்கு, என்ன நடந்துச்சுன்னு. we should go with the patient. We should be in their side. எனக்கும் என்ன நடந்துச்சுன்னு தெரியல. I agree with you. வந்து பார்த்தா இசிஜியில் பார்த்தா ஏதோ மயக்கோலல் இன்ஃபெக்ஷன் சொல்றாங்க. இப்போ நானே அட்மிட் பண்ணாம ஓபியா பார்த்துட்டு வாங்கன்னு சொல்லி எழுதி கொடுத்துட்டு போயிருந்திருக்கலாம். பட் ஐ டென்ட் டூ தட். ஐ டுக் த ரெஸ்பான்சிபிலிட்டி, ஸ்டாஃபோட தான் அனுப்பியிருக்கேன். எம்ஆர்ஐ எழுதி கொடுத்துட்டு முடிச்சுட்டு ஈவினிங் வாங்கன்னு சொல்லிட்டு போயிருந்திருக்கலாம். ஐ டென்ட் டூ தட். அப்படின்னா உங்க ரெஸ்பான்சிபிலிட்டியா போயிருக்கும். நான் தான் ஐ டேக் த விக்கார் ரெஸ்பான்சிபிலிட்டி. சார் நீங்க என்ன சார் தப்பு பண்ணி, நீங்க தப்பு பண்ணிருந்தாங்க. அப்படி இல்லை, தப்பை நான் கழிச்சு விட்டு போக முடியாது. பிகாஸ் விக்கார் ஐ ஷுட் டேக். உங்களுக்கு நான் வந்து ஐ கிவ் அ 5 ஆப்ஷன்ஸ். ஒரு ஆப்ஷன் வந்து first I am very clear he is not going to survive. I will continue treatment in the ICU. 1. உங்களுக்கு தெரிஞ்ச எந்த டாக்டர் வேணாலும் வந்து பார்க்க சொல்லுங்க. நம்பர் 2, உங்களுக்கு தெரிஞ்ச கார்டியாலஜிஸ்ட் வந்து பார்க்க சொல்லுங்க. இல்லை அதை ப்ரூவ் பண்ணணும்னா கார்டியாக்காக நான் ஆன்ஜியோக்கு வேணா ஐ வில் சப்ஜெக்ட் த பேஷண்ட் ஆன்ஜியோகிராம். பேஷண்ட் வந்து ஸ்டில் அதுக்கப்புறம் டெத் ஆகுது, பேஷண்ட் டெத் ஆகிட்டாலும் லெட் அஸ் சென்ட் த பேஷண்ட் ஃபார் கிளினிக்கல் போஸ்ட்மார்ட்டம். அதில் என்ன தீர்ப்பு வருதோ நானும் ஏற்றுக்கிறேன், நீங்களும் ஏற்றுங்க. இட்ஸ் யுவர் ரைட். யூ சென்ட் ஃபார் கிளினிக்கல் போஸ்ட்மார்ட்டம். அதையும் மீறி உங்களுக்கு சந்தேகம் இருந்துச்சுன்னா யூ sue me. I will face in the court. என்னோட எவிடன்ஸ் கொடுக்குறேன். எது நியாயம் வருதோ ஐ ஆல்சோ அக்செப்ட், யூ ஆல்சோ அக்செப்ட். இதுல என்ன சொல்ல வரேன்னா, டோன்ட் எவர் கோ ஃபார் அவுட் ஆஃப் த கோர்ட் செட்டில்மெண்ட். இதுதான் நான் சொல்ல வரேன். அது மாதிரி தப்பு யாரும் பண்ணாது. பணத்தை கொடுங்க, let us go and legal. That is the safest option. That is the safest option. ஏன்னா நம்மகிட்ட ஒன்றும் இல்லைன்னா லீகல் போங்க. இங்க 6 ஆப்ஷன். ஏன் மேலே sue பண்ணுங்க, உங்க ரைட்ஸ் இருக்கு. You have the rights because I respect your rights. You can sue me. I subject myself to that. அடுத்து நான் வந்து கும்பிட்டுட்டு ஏஎம்ல போயிட்டாங்க பேஷண்ட். So this is where communication stands. மத்தவங்க சொல்றத perspective சொன்னா நல்லா இருக்குன்னு நான் நினைச்சேன். And this is what, and well-versed knowledge of the law is a requirement for anyone who handles hospital patients. Those hospitals and physicians who do the right thing and practice good medicine that puts the patient interest first will generally not have to worry about being on the wrong side of the law. கருமம் சிதையாமல் கண்ணோட வல்லார்க்கு உரிமை உடைத்து இவ்வளவு. Thank you. Thank you, sir.
Dr. Thiruppathy, I mean, it was like a legal luminary talking, giving a lecture. And many of the things, I mean, really amazing lecture. And I learned so many things which I didn't learn so long. And one or two things which come to my mind. One is, you said the disability certificate can be given by the treating doctor. Nowadays, I think they have changed it. That disability certification should be done only by the medical boards, the government medical college hospitals.
No, sir. No, sir. No, sir. No.
No,
only for, sorry, sir, sorry, that is only for government employees, not for any patient.
Even the insurance companies, they are asked to take a percentage of disability only from the medical board. And if they want to give any disability, the percentage calculation, it is only accepted from the government medical boards. I think it is a recent this thing.
Private. I'm not aware, sir, but until recently, there's a strict guidelines given by the Central Ministry of Social Justice. They are given the guidelines to work on it, how to work on it. That's very interesting to work on disabilities. As a formula is there. There's a telescoping formula is there.
Yeah.
And maybe I may not be updated. I'll check it again, sir. But to my knowledge, yes, I will take it from you, sir. I will check it again and let you know. Post it again, sir. From the, I will check it again and put it, sir.
Second thing was this. Nowadays, you cannot operate on do a brain surgery without having a CT scan in-house in the hospital. That is another recent judgment. One of the judgments came. If you don't have a facility for doing a CT scan, especially for post-operative, immediate post-operative cases, you should not operate, brain surgery in that hospital.
That's a new thing, sir. I'm not aware that's a new thing. And I will say that's a welcoming thing. That's a welcoming thing. That's a welcoming thing.
That is another thing. Similarly, same thing with cardiology also. No, if you don't have a cardiologist in-house or visiting cardiologist, you should not treat myocardial infarction. A general physician cannot treat myocardial infarction. These are things which came to my mind, and it's an amazing lecture, and you have made it so simple. And this thing, I wished I would listen to the informed consent paper also. Consent this thing.
And the proposals, what you are saying is actually medical federation should welcome it. Rather than it should be welcoming moves.
Because the accidents like what you said, on the MRI table patient collapsing, if it happens within the hospital premises or something better could have been done like that.
Yes, sir, sure. That's right. Yeah. That's why, for example, I put myself first rather than others.
Yes.
Please, sir.
Thank you, Dr. Thiruppathy. Very useful, and very happy that we got you on board for this talk. A lot of interesting things which many people may not be aware. I'm glad you emphasized on the point that every page of
President sir, 1 minute, sir.
Yeah.
We will go to the third question and fourth question,
Sure.
and then we will start discussing.
Sure.
Because now we will go for the third question. Naveen, which among the following nerve fiber is not seen in the peripheral nerve? Okay, you can carry on.
Yeah, so the things that you mentioned, like every page of the consent and discharge summary to be signed, hardly anybody knows it, and I don't think anybody is getting it. And signature on every page. It's a very essential thing, and I'm glad you emphasized on that. The other thing was about the immediate discharge document. It's nice that you said use the word document and not summary. Yeah, I think that's a very nice aspect. So the patient cannot claim that they didn't give a proper summary. You are very clearly saying it's a immediate discharge document, and maybe one line can be added later in that summary, the document, that regular discharge summary will be given during working hours in the next 24 hours.
Yes, sir.
Something like that could possibly be added to make it clear that this is not the final document and that there is another document coming. Now, regarding discharge at request, I think there is no such clause available at all. Either it's a discharge or AMA. There is no discharge at request.
Yes.
There is no legal provision for discharge at request. So,
Yes, sir, I mentioned the slide like that only.
okay.
But what I would say, that's why I'm saying that. Yes, definitely you are right, exactly right. But you put a moral binding on the patient. See, understand? நம்மள கையெழுத்து போட்டு கூட்டி வந்திருக்கோம் அவனுக்கு தெரியும்ல. See, you avoid further. See, இந்த சட்டப்படி இல்லாட்டியும் நம்ம தான் கையெழுத்து போட்டு கூட்டி வந்தங்கிறது mandate இல்லாட்டியும் ஒரு morality இருக்கும்ல.
So the recommendation is make it as AMA. Don't even encourage them.
But சில பேஷண்ட் இருப்பாங்க சார், நம்மளுக்கு நம்ம ஸ்ட்ரிக்ட்டா இருந்தாலும் we cannot hold the patients also. ரொம்ப ஸ்ட்ரிக்ட்டா ஏஎம் கையெழுத்து போடு நான் பொறுப்புலங்கறப்ப சில பேஷண்ட் இருப்பாங்க, சில வீட்டுக்கு போறேன்பாங்க, டிஸ்சார்ஜ் வீட்ல பாத்துக்கறாங்க, ஆன்டிபயோட்டிக்.
What I usually do in that situation is I just tell the family it's just a formality, we need to get it signed, don't put
requestங்கறப்ப அவனுக்கு நம்மளுக்கு ஒரு சும்மா ஒரு குட் டாக்டர் ரிலேஷன்ஷிப் என்ஷூர் பண்றப்ப நம்ம நம்ம ப்ரொஃபஷனல் கட்டனேட்டா இருக்க முடியாது சார். கொஞ்சம் நம்ம we should be also. இப்ப ஹானஸ்டா சொல்லணும்னா நம்ம ஆல்கஹால் ஹிஸ்டரியை மென்ஷன் பண்ணோம்னா ஒரு எம்எல்சி கேஸ் காம்பன்சேஷன் வராது.
கரெக்ட்.
ஆல்கஹால் ஹிஸ்டரியை மென்ஷன் பண்ணோம்னா.
But as doctors, I don't think we should take the risk of hiding it, because we can get into trouble by doing that.
Hiding வேண்டாம். not to mention எல்லாம் என்ன பண்றோம்? not to mention. அத பத்தி மென்ஷன் பண்ணாம அப்படி கடந்து போயிடுறோம், அவ்வளவுதான்.
So again, in head injuries it becomes a problem, because we know that in some head injuries the patient is drowsy because of the alcohol intake, and for that reason, for this subdural, even with this GCS, we did not operate. So unless that alcohol history is documented, it's going to be a problem.
அது வந்து பர்ட்டனிங் அந்த கேஸ் troublesome கேஸ்ல பண்ணியே ஆகணும் சார்.
Exactly.
ஒரு மைல்ட் ஹெட் இன்ஜரி, தண்ணி அடிச்சு படுத்திருக்கான், எல்லாருக்கும் அப்படி பண்ண ஆரம்பிச்சோம்னா what happens is different hospitals will not like it.
Yeah. So
நான் வந்து practical tips சொல்றேன் சார்.
Yeah, I know practically it is there, but we have to play it very carefully. It might become worse in the future.
உங்களோட எக்ஸ்பீரியன்ஸும் எக்ஸ்பர்டைஸும் choosing the right patient, choosing the right
doctor. Sir, the fourth question.
Yeah.
Which among the following is not probable diagnosis? In the presence of autonomic disturbances. Yes, sir. Go ahead.
So continue. You also said that not taking a written consent is not negligence. I'm not sure of that. I think not taking a written consent is negligence.
Definitely.
Okay, Naveen.
I will elaborate this statement in the next meeting, sir.
Okay, yeah, the next topic, just for information.
Only for consent. Only.
For Dr. Ramesh's information, the next talk in Dr. Thiruppathy series is going to be exclusively on consent. He will detail it next month. And the other thing is regarding fees waiving. What I have always been practicing from the beginning is if a patient wants the fees to be waived, I ask them specifically to write a letter saying that they are not able to pay the fees for this reason to the hospital administrator. They have to write it, sign it, and give it. And I second that document and only said it. Only with this, that request has been made, only for that reason we are waiving. Like you said, if you waive without them asking, or they can say we didn't ask, they waived, so they might even suspect us. So never waive a fees without a proper request from the patient or the family side. The last thing you said about sending this material for the pathology. I know a doctor who sent the subdural fluid for pathology analysis. And believe it or not, they found a pathology in that, and the patient had a malignancy elsewhere, which was not detected previously. I don't know, probably the only patient he sent, I don't know how many he has sent this regularly, but they found out a hematological pathology in the subdural fluid which was not found in the regular blood test. But I don't know, can we send the subdural fluid for
fluid can be, yes. What is, sir, நம்ம ஊர்ல பொறுத்த வரைக்கும் documentation matters. நான் அனுப்பிச்சிட்டேன் அப்படி காமிச்சா I agree. And I always said subdural membrane, neomembranes I sent. Neomembranes. Pseudomembrane, neomembrane I sent. And one occasion I was just mentioned, one case an operated on a ICH, intracellular hemorrhage, spontaneous ICH. When I do it in the microscope, I found some area of some membrane, something is there, some tissue. Just my intuition said. I took that and sent for biopsy, came as GBM. I have 3 cases. I present also 3 cases where it's presented as an intracellular hemorrhage, turned out to be a glioma of the bleed, which we cannot suspect from the MRI alone.
Previous MRI.
3 cases, subsequent opportunity I will show it in post it there. And that case gave me a very, and always when I evacuate ICH, spontaneous ICH, I look for it somewhere. Anything suspicious there. 3 cases here.
We do look for cavernomas, small AVMs.
I have 3 cases.
Yeah, small AVMs, cavernomas. So it's better to send the ICH. But subdural, I'm a little skeptical about spending.
Sir, what is that 300 rupees?
Yeah,
you have some additional documents.
Sure. So thank you once again, wonderful lecture, and we look for
one more comment I just want to make.
Thank you.
Dr. Thiruppathy, I mean, just one question. This is not related so far, whatever this thing. Sometimes radiologist report is at variant with our impression. Clinical impression, we see clinically as well as the image also. So our interpretation is slightly different and radial report. So in that situation, how to tackle? Suppose this case goes to insurance companies mostly depend on the radiologist report, not our report, our perception. So how to tackle this?
2 things, sir. I will also reveal a trade secret also here. I will also reveal a trade secret also here. This, see, radiologists mostly they give a disclaimer. This is only radiological interpretation.
Yeah, but
interpretation kindly correlate clinically. Okay. What I did was to first thing is better always to communicate with the radiologist and reread the report. If at all we have some communications, that is the best thing to do. Definitely that should be done. We should be communicating with the radiologist. If at all suppose phone money, we are directly communicate with the radiologist and sort the issues, and you can get the report and reread it return. That is best way to do this. And the trade business point of view, just I will reveal a secret. Since they are giving that loophole to us, kindly correlate clinically. What I do in my hospital is, I also sign referral Thiruppathy. Clinician is Dr. Thiruppathy. Clinically interpreted correlated by Nanu. And I get a fees for that also. Legitimata. Since he is giving an option, radiologist is giving an option, he is giving a, say that you correlate. Yes, I am correlating. So, I also sign in the radiology report, clinically correlated interpreted by so and so. I put my C. This is validate. Fees. What happens, unfortunately or fortunately, our hospital was subjected to the Watson raid of enforcement directorate raid came to our hospital. And this question was raised to the enforcement directorate whether this financial practice is right or wrong. The top financial expert enforcement directorate said, this is a fair practice because he has correlated, he has taken the fees and he has paid tax also for it. What is wrong in this? நான் ரெஃபரல் ஃபீ வந்து ஒரு MBBS டாக்டர் ரெஃபர் பண்றது வேற, நம்ம ரெஃபர் பண்றது வேற. சிடி ஸ்கேன் நம்ம பார்க்குறோம், MRI நம்ம பார்க்குறோம். அவன் ரெஃபர் பண்ண கட்ஸ் நம்ம பண்ண கட்ஸ் கிடையாது. நம்ம தேவையில்லாம அவனோட போட்டி போடுறோம். ரெஃபரல் டாக்டரோட, ஹோமியோபதி டாக்டரோட போட்டி போட்டுட்டு கட்ஸ் நம்மளே நம்ம வந்து we are demeaning ourselves. Legitimately, we have made a routine for past 8-10 years, and every month, to be honest, I am getting a good income out of it also. Legitimately, which I am sharing with my colleagues. Yes, because you are saying correlate. Yes, I am correlating and giving a seal. I also share the responsibility. And actually, more than the radiologists, we are taking the burden. Night, நம்ம தான் பார்த்து ஆப்ரேட் பண்றோம், எல்லாம் பண்றோம். அவங்க வந்து அடுத்த நாள் தான் ரிப்போர்ட்டே வருது பெரும்பாலும். அப்ப நம்ம வந்து அதை பண்ணி கட்ஸ் நம்மளை சிரமப்படுத்திக்க, நம்மளை வந்து இன்ஃபீரியர் படுத்திக்க தேவையே கிடையாது. We can put our head high. Yes, it's my clinical thing. I am also interpreting it, and I am not hiding to the patient, and I am legitimate to get and paying the tax and become legitimate. I am happy. It's a win-win situation, sir. This is a trade secret also I am living. Please, thank you.
Just to supplement what Dr. Thiruppathy said, whenever there is a discrepancy, I do exactly what he does. I call the radiologist. Even today, I had to call a radiologist in another scan center and tell them this is the clinical picture. Your image is not correlating. What do you want to do? He said, "Oh, I never knew that, sir. I didn't see that in that aspect. Please send the patient and the report back again." Now, what I do is in the note today's prescription, I will add that discuss with this doctor radiologist about phone about this radiology discrepancy. He said he will review and give a second fresh opinion. The second thing is, if it is done at some other hospital and I still disagree, it's easier for me to get a second opinion in my hospital itself. If the other doctor refuses to do it, if it's done in my own hospital, then it becomes a problem. If my MRI radiologist says an opinion which I'm not accepting, and even here I send it to another hospital, another group hospital. For example, I'm in specialty, I send it to Dr. Shanthanam in Maine to get a second opinion. If both of them concur, then I really rethink my opinion or take another neurosurgeon's opinion before I proceed what to do. And I think we have to do, talk to the primary radiologist, talk to the second radiologist if necessary, and sometimes take a second opinion directly, as Dr. Thiruppathy said, in any difficult case.
And to add on that, exactly the case which I cited as an example, that case turned out to be a spontaneous intracranial hypotension, not bilateral subluminal. My suspicion was right. So that also saved my day. Next, sir, please.
Dr. Rajesh, can
There are no further discussion, sir.
Yes.
The winners for this quiz were only first two questions only the answers were given correctly, and third and fourth the wrong answers were given. And for the first question, what percentage of diabetic patients develop neuropathy in their lifetime? The answer is 50%, the C. The winner is Dr. Nagavishnu Shankar. Nagavishnu Shankar available?
Yes, sir.
Congratulations.
Thank you, sir. Thank you, sir.
Then the second question. Most common cause of mononeuropathy is carpal tunnel syndrome. Answer. And the winner, first responder is Dr. Tamilnadu. Tamilnadu available?
Yes, sir. Good evening, sir.
You are from which college?
Meenakshi Mission, Madurai, sir.
Congratulations.
Thank you, sir.
Now the third question. Which among the following nerve fiber is not seen in the peripheral nerve? Answer is A, large unmyelinated. No one was correct. And then question number 4. Which among the following is not a probable diagnosis in the presence of autonomic disturbance? Is B12 deficiency is the answer. So these are all the 4 questions and answers, and congratulations to the winners. Actually, Thiruppathy sir, நீங்க பேசுனது வந்து ரொம்ப எக்ஸாஸ்டிவா நல்லா தான் இருந்தது. பட் ஒன்லி திங் வந்து இன்னைக்கு பேசுனதே வந்து நீங்க வந்து 3 டாக்கா கொடுத்துருக்கணும். இது ஒரே ஒரு டாக்கா கொடுத்தது வந்து முக்கால்வாசி புரியல, முக்கால்வாசி வந்து கிரகிக்க முடியல. அதனால வந்து இது வந்து ரொம்ப எவ்வளவு பாயிண்ட் சொன்னீங்களோ அத்தனை பாயிண்ட்டையும் வந்து நம்ம வந்து மனசுல வச்சுக்க நிக்க வைக்க முடியல. அந்த மாதிரி. அதனால வந்து நீங்க வந்து உங்க டாக்க வந்து இனிமேல் வந்து ஈவன் கன்சென்ட் மாத்திரம் எடுத்தீங்கன்னா கூட அதை வந்து நீங்க கண்டினியூஸா 1 hour பேசாதீங்க. யூ டாக் ஒன்லி 15 minutes 20 minutes பேசி நிறுத்திடுங்க. அதுல டிஸ்கஷன் பண்ணுங்க. கன்சென்ட்டே வந்து நீங்க வந்து 2-3 டாக்கா பேசணும். இந்த ஒத்த டாக் ஃபுல்லா பேசிட்டே இருந்தீங்கன்னா ஒண்ணுமே நிக்காது கடைசியா. இம்பார்ட்டன்ட் ஆக்சுவலா. இப்ப நீங்க பேசுனது இத்தனையுமே வந்து ஒரு ஒர்க் ஷாப் மாதிரி வைக்கலாம். இதை வந்து ஒரு ஒர்க் ஷாப்பா we have to conduct. ஈவன் ஃபார் அவர் மெம்பர்ஸ் இட் செல்ஃப் நம்ம வந்து இதுக்கு வந்து தனியா ஒரு ஒர்க் ஷாப் மெடிக்கோ லீகல் ஒர்க் ஷாப்னு சொல்லிட்டு we can conduct a workshop for this actually. இப்போ இந்த பார்ட் மார்னிங் இந்த இதை மாத்திரம் சொன்னது மாத்திரமே we can have a 3 hour discussion. ஒன்றுக்குமே வந்து ஒரு கோட் பண்ணி இன்னொன்னையும் வந்து எக்ஸ்பிளைன் பண்ணி we have to do it. ஏன்னா அதுல வந்து மெடிக்கோ லீகல் கான்செப்ட்ஸ் வந்து நான் வந்து முதல்ல இருந்த ஃப்ரம் நான் எம்பிபிஎஸ்ல இருக்கிறப்ப நான் வந்து ஆக்சுவலா வந்து செஷன்ஸ் கோர்ட் போய் ஃபேஸ் பண்ணியிருக்கேன். கேஜி ஹாஸ்பிட்டல் நான் ஒர்க் பண்ணப்போ நான் செஷன்ஸ் கோர்ட் போயிருக்கிறேன். திருச்சிக்கு தான் வந்தேன். செஷன்ஸ் கோர்ட்ல வந்து கேள்வி கேட்கறது வந்து பயங்கரமா இருக்கு. அவன் அந்த ஜட்ஜு கேட்கிற கேள்விகள்லாம் வந்து அந்த லாயர்ஸ் கேட்கறது ஒன்றும் ஆன்சரே பண்ண முடியாது. அந்த மாதிரி கேட்பாங்க. ஸோ அதனால வந்து எனக்கு வந்து அப்ப இருந்தே வந்து அதுல எல்லாம் ரொம்ப லாஜிக் இன்ட்ரெஸ்ட் ரொம்ப இருக்கு. ஸோ அதனால வந்து ஐ ஹேவ் லாட் ஆஃப் எக்ஸ்பீரியன்ஸ். ஈவன் வந்து இந்த கோர்ட் சம்மன் கூட பாத்தீங்கன்னா நீங்க கோர்ட் சம்மன் பத்தி வந்து நீங்க சொன்னீங்க நீங்க தபால்ல வாங்காதீங்கன்னு சொன்னீங்க. ஆனா இது வந்து ஹாஸ்பிட்டல்ல வாங்கிட்டு நான் ட்ரீட்மெண்ட் நான் அந்த கோர்ட்டுக்கு போகாம விட்டு அரெஸ்ட் வாரண்ட் அனுப்பிட்டாங்க. அரெஸ்ட் வாரண்ட் அர்த்தம் எப்போ வரும்னு அதை நீங்க சொல்லணும். அது எப்போ வரும்னா ஃப்ரைடே ஈவினிங் தான் வரும். ஃப்ரைடே மத்தியானம் காலையில ஒரு 12 மணிக்கு வருவாங்க. ஏன்னா இவங்களை அரெஸ்ட் பண்ணிட்டு மண்டே கோர்ட் இருக்கும். நீங்க வந்து சனி ஞாயிறு ஜெயில வச்சுட்டு மண்டே வந்து கூட்டிட்டு போறது இதுதான் பண்ணுவாங்க. அதுக்கு வந்து சரி அந்த ஹாஸ்பிட்டல் ஓனர் வந்து அவர் வந்து அவங்ககிட்ட பேசி அவர் டாக்டர் வர சொல்லி இருந்தப்ப நான் மண்டே எப்படி இருந்தாலும் அதனால நீங்க போயிருக்கேன்னு சொன்னதுனால சரின்னு தப்பிச்சோம். இல்லைன்னா என்ன ஆயிரும்?
ஒரே விஷயம் சார், சம்மன் நம்ம தான் கையெழுத்து போடணும். தெளிவா வச்சுக்கணும். சம்மன் நம்ம கையெழுத்து போட தான் செல்லும் சார். சம்மன் நம்ம தான் கையெழுத்து ரிசீவ் பண்ணணும். ஹாஸ்பிட்டல் ரிசீவ் பண்ணது போகணும் அவசியம் இல்லை. அப்புறம் இன்னொரு விஷயம், இந்த டாக்கை தப்பா எடுத்துக்காதீங்க. இட்ஸ் ஓவர்வியூ. இது என்னன்னு தெரிஞ்சுக்க தான் ஓவர்வியூ. ஸ்பெசிஃபிக்கா போனா we can go on. இந்த டாபிக்கே ஓவர்வியூ.
ஜெனரலா நான் சொல்றேன். ரொம்ப எக்ஸாஸ்டிவ் இது.
No, this is actually what we had planned. Me and Dr. Thiruppathy had planned was to have a series of at least 3 to 4 talks. The first one, overview, second was consent, and one talk of a case which case the neurosurgeons won, and another talk where neurosurgeons lost. At least a 4-part series depending on the interest and the with the audience need. So I think there is a definite need for this. We will complete the 4-part series, and then depending on what more needs are there, we will add on any specific topic like how to appear in a court and what questions will be asked, how to answer them. That's also a very good suggestion. Maybe that should also be incorporated in, because many people for the first time when they're going, or even a second or third visit, they may not know how to handle it, and it's a very essential part of our skills these days. So good talk once again, Dr. Thiruppathy.
Thiruppathy, also you must talk on most of the things we have been showing how we will be caught in the law. You must also highlight how we are protected by the law. What way law protects the medical practitioners or doctors. What are the protective measures in the law for us? Otherwise, everybody will get afraid, frightened. So many things you will get into problem and all that. Probably that also you can talk in one of the lectures.
If our discussions are over, we can go for the vote of thanks by Dr. Kodiswaran sir.
Thank you, Rajesh sir. It was a wonderful TAN CME. I would like to thank the first speaker of Shanthanam and Thiruppathy sir. Thiruppathy sir is well known for his legal aspects always. Thiruppathy sir, it was a wonderful talk. Actually, due to some busy schedule, I was coming in between and going. Anyway, it is a detailed discussion. Actually, I had a multiple bad experience related to this legal aspects. When I was one important event, when I was working in Vellore Medical College, district collector gave an order that you should give immediate disability certificate in OP for this compensation. For every month they used to get 1,000 rupees. So I issued a certificate without any delay. One patient came, because if it exceeds 50%, they'll get 1,000 rupees. Collector has given instruction, you should give it immediately without any delay within a day. So I issued a certificate stating that 60% disability. That time the OP will be very crowded, so we don't keep any backup documents. That fellow, what he did, he gave the document to compensation claim in a RTA. So it was signed as Dr. Kodishwaran, Professor of Neurosurgery, Vellore Medical College. That fellow presented in a sessions court. So sessions judge gave me a summon and I went there. And the first question he asked me, did you issue this certificate? That fellow was claiming 7 lakh rupees with the government compensation disability certificate. So I told sessions judge that this certificate was issued by me. Then that judge asked me, give me the backup documents. I don't have anything because it was issued in a OP. So then he asked me, you are a professor of one medical college. You are issuing one certificate stating that 60% disability, but you don't have any backup documents. That time only I realized we should not be in a hurry to issue any certificate or something without proper examination and documents. Even somebody pressurized us also. So this kind of experience I had in my personal situation. So as our president and secretary said, it should be discussed because one major advantage, you are a lawyer come neurosurgeon. So then only.
No. I'm a neurosurgeon helping my friend.
No, then only the neurosurgeon's pain will be understood by a lawyer. So always, if he doesn't know the practical difficulties of a neurosurgeon, he cannot discuss the things properly. So as our president and secretary said, we should divide into multiple topics. At least in every CME, you should discuss about in one part how to take a consent. Today also we got a summon from a court. You should issue the death certificate immediately for an MLC patient. So the policeman came to our department. He was asking the death certificate. So we actually every day at least we are seeing 1 or 2 deaths. So suddenly we cannot get the documents also. So we have to go to MRD. So a lot of difficulties there in government service also. So like you should be divided into multiple parts, at least 5 to 6 topics, and you should explain us properly. So it will be a knowledge sharing event for us. Thank you, sir. Thank you one and all for joining everyone for this chance here. Thank you, sir.